And Mike, the public part begins at, with the 11 o'clock opening, right?
That's correct.
Yeah, that's what
We
I thought.
start public and 2 o'clock we go private.
Yeah, this will be interesting.
Yeah.
Morning, Mark. Good morning, Mike.
Morning.
Good morning.
Mike, I understand we have 30 minutes for each speaker. Is that correct?
I thought it was 50.
All right. Can't pull anything over on you, McGinnis.
Right.
Morning.
Morning.
Good morning.
Morning all.
Morning.
Morning, Dr. McGinnis.
Good morning. Mark, we can start whenever you're ready.
All right, great. Well, let's start. Let me begin by welcoming all of you who are with us today for this fall meeting of the National Academy of Medicine's Leadership Consortium for a Value and Science-Driven Health System. This is a particularly important time for the work of the consortium, as you'll hear about today. Welcome you as well on behalf of the National Academy of Medicine team, led by Dr. Michael McGinnis, who we'll be hearing from momentarily. And this is like with many meetings these days, this is a kind of a new format for us with much more of a web presence. We have a number of additional participants in the meeting today. Welcome to all of you, and I hope you'll continue to be part of our activities with the Leadership Consortium going forward in this new virtual format, at least as we're getting through the pandemic. I'm the director of the Duke Margolis Center for Health Policy at Duke University, and I have the privilege of working with a very diverse group of leaders who are part of the consortium. You'll be hearing from many of them during the course of the day, as well as some special guests, and we'd like to thank you for being here with us today as well. We're going to focus in this meeting on the effects of the COVID-19 pandemic on the healthcare system and reflect on both the challenges this crisis presents as well as the opportunities it's opened up to drive transformation towards a more equitable, efficient, and effective healthcare system. Before we get started, just a few housekeeping items. Please mute your line when you're not speaking. Remember to unmute when we call on you to speak. We'll remind you about that as well. For those of you who are joining us in the broader audience today, please use the Q&A feature in Zoom to type in any questions or comments that you'd like to bring to the attention of the group, and we'll try to get to as many of those questions as possible. For consortium members, the panelists, the authors, the speakers, remember that you have the chat feature available for messaging the host of the meeting as well as other panelists. So make sure you're signed in using your unique panelist link so that you've got that capability available. If you sign in through the general registration link by chance, please contact Anjana or Therese via email for further instructions. So I'm going to come back to the agenda in a few minutes, but before we get into the details of the meeting, I'd like to turn to Mike McGinnis for a broader overview and update, and welcome to the group.
Thank you very much, Mark. And I want to thank all of you for joining in the session, both those with the Leadership Consortium and those who are engaged in the public. This is a really wonderful opportunity for us to work with multiple sectors and contend with some of the most compelling challenges of the nation. I noticed that, Ariana, just for your mention, that I am not visual here, so if I could somehow get onto a visual, that would be terrific. Can you manage that from that
Yeah,
end?
stop the screen sharing.
Hi, Michael. I'll be sure to get that. But please continue, and I'll work on that while you're speaking, okay?
Okay, well, I'm going to plunge ahead while we work that out. As Mark alluded to earlier, we're dealing with a situation of novel venues, which is a good thing in some ways, also has its own unique challenges. In the way of, I've basically got three things I want to cover. One is welcome and thanks to all of you. A second is a little comment on the venue issue and its implications. And then mostly an update on the Leadership Consortium and the work that we're doing through the consortium and the National Academy of Medicine with the Leadership Consortium members, their constituencies and the sectors that they represent, as well as many of you who are tuned in today for the session. By way of thanks, I want to especially thank not only those of you who tuned in, but our chair, Mark McClellan, who's provided fabulous leadership and guidance to us throughout the course of our work. Of course, he's drawn in many directions to provide that leadership and guidance in many other venues as well. And so we're privileged to have your guidance, Mark. Thank you very much. I want to offer a special note of welcome to our new members who are with us today. We have from AstraZeneca, Raquel Beria, who is the Vice President and Head of Medical U.S. Biopharmaceuticals. And she's accompanied by Jeff Hurd, who's been with us previously. Welcome to Nikayla Cook, who's the Executive Director of PCORI. And we've already put her to substantial work, as you'll hear in a few minutes. Welcome to Adam Gluck, who is the Senior Vice President, U.S. Global Affairs for Sanofi. And his colleague, Eric Racine, is also with us. Welcome to Adam Lankowski with Bristol Myers Squibb, who's General Manager and U.S. Head of U.S. Commercial. Annette Powers is Vice President for Strategic Payer Marketing, and she's serving as point person as well for Bristol Myers Squibb. John Whitney has replaced our Craig Samet, and after him, our point person for Anthem, and John is the head of Anthem Medical Policy. Also with us is Lee Fleischer, who's the Chief Medical Officer of the Centers for Medicare and Medicaid Services. In addition, we have Michael Iademarco and Brian Moyer from the CDC. So welcome to each of you, and thanks for joining us. And as mentioned earlier, when I referenced Nikayla, we've put many of you to work already. I also want to offer thanks and welcome to our new staff. We have two new staff as members of the consortium staff. Ariana Bailey, who is having the maiden voyage, if you will, and fielding the logistics. And Aisha Williams, who has come in as a research associate and is helping throughout the work as a whole. And finally, I want to welcome not a new staff, but a new role, Ayadola Nishe, who has agreed to sign on after a little arm twisting to serve as my deputy. So again, thanks and welcome to each of you. The venue that we're dealing with is one that obviously all of us have deep experience now with the virtual world. And we found not only that it's efficient in some ways, but it's clearly fatiguing as well. So we've shortened our meeting. And we'll be talking in our executive session later on about the best ways to move forward in the scheduling and cadence of our Leadership Consortium meetings. We do want to take advantage of the virtual opportunities, but we also want to, as the conditions improve vis-a-vis the pandemic, we want to make sure that we do have the opportunity to bring people together. Obviously today we've taken advantage of the circumstances by opening it up to the general public. Our meetings are always filled with very rich conversation and informative engagement of key issues. And so it's desirable for us to share that where we can, and we'll talk more about that also in our executive session. So that brings me to the slides for update. And although I've got 10, I'm going to be very quick. I guarantee you that I'll keep it to an average of no more than 30 seconds. Because I can't quite, there they are. The first slide up is I can't quite see it because of the circumstance, but let me just see here. Okay, the Leadership Consortium is made up of stakeholder leaders in public, private, independent organizations from key health sectors, collaborating under the auspices of the National Academy of Medicine for action on their common interest in advancing effectiveness, efficiency, and equity in health, medical care, and biomedical science. We've been operating now for a little over a dozen years, and we've been uniquely positioned in that respect, and that'll become apparent in just a second. Next slide, please. For the time of our operation since 2006, we've operated under the vision of a learning health system. A learning health system is one in which science, informatics, incentives, and culture are aligned for continuous improvement, innovation, and equity, with best practices seamlessly embedded in the delivery process, individuals and families, active participants in all elements, and new knowledge generated as an integral byproduct of the delivery experience. Next slide, please. Our focus has been collaborative action. Next slide. You'll see that as I run quickly through these other slides. And the collaborative action is oriented around those four dimensions of science, informatics, incentives, and culture. I'm not going to go through the elements of all of these slides in the interest of time because you'll have them available. We'll send them to everybody afterwards. But just to note that there are commonalities throughout all of the four foci. We have an evidence mobilization action collaborative to advance the work on science. We have forged anchor principles for stewards of evidence development. And we are in the process of developing core indicators of progress, in addition to developing projects around and important for the major gaps in our policy and program leadership. Next slide, please. In the issue of informatics, it's essentially what you see here is the same framework for activity with anchor principles, core indicators that guide our digital health action collaborative, and a series of key activities that are engaging fundamentally important issues to the field: artificial intelligence and machine learning, the issue of health equity, AI, and algorithmic integrity, and so forth. Next slide. In the incentives arena, again, we have developed anchor principles that are being rolled out through networks of collaborating organizations, developing a series of core indicators that we'll use for assessing our national progress. And we're in the process, as you'll hear in a minute, of developing a substantial focus on the issue of financing that rewards better health and well-being. What are the payment structures that are most important in this respect. Next slide, please. In the culture arena, our Culture, Inclusion, and Equity Action Collaborative, again, anchor principles and core indicators, a series of activities that are aimed at activating and providing tools for patient, family, and community engagement, as we've all learned is so essential for progress in every dimension of our activities. Next slide, please. COVID-19 has presented us with a perfect storm that provides poignant and painful reveal of system fragilities, a novel, highly contagious, lethal virus, a public health system poorly supported, a medical care system highly resourced but fragmented medical supply lines, care financing system that's unaligned to the population's health, groups who are vulnerable from systemic bias and neglect, and you could identify, or each of you could identify 2 or 3 more for the challenges that have been put into stark relief by our experience. A common lesson is that science, informatics, and incentives and culture matter. A lesson that may be even more compelling, certainly for our discussion today, is that their alignment matters even more. Next slide, please. So our focus at this point and in this meeting is on the issue of strategic alignment, aligning science, informatics, incentives, and culture through the sectoral assessments that we're going to hear about today, because we are uniquely positioned as an organization with sector representation and the leadership of the key sectors represented to be able to assess in progress the challenges that are being presented by the COVID pandemic, and not just the challenges in terms of responses to pandemic and infectious disease circumstances, but really systemic challenges that require attention as we move forward. So you're going to hear today the reports from an extraordinary set of sector leaders about the work in progress. We're going to also discuss a little bit about the sector and system-wide priorities for transformation, which will become an ever-increasing focus. And then we will not talk about today, but we will keep you informed about our progress in developing a focus on financing that rewards effectiveness, efficiency, and equity in health. So next slide, please. The day will have us reviewing the sector leadership and assessments in patients and families and communities, clinicians and professional societies, care delivery organizations, digital health, state and local public health, healthcare payers, health product manufacturers and innovators, health and biomedical research, and quality, safety, and standards organizations. So again, thanks to each of you for being with us, and special thanks, of course, in advance to our sector leaders and collaborators who we'll hear from in a bit. Mark, let me turn it back to you.
Great. Mike, thanks very much for that overview. Lots of work going on. So just to go over the agenda for today in a little bit more detail, we're first going to have the privilege of hearing from someone who has been very busy lately, Surgeon General Vice Admiral Jerome Adams. Jerome has been very active in trying to convey the important public health messages in this pandemic, as well as the important public health messages that were present before and we still need to pay attention to in the pandemic as well. Has some really thoughtful views on where we are and how to move forward in light of COVID-19 and the road ahead and this unprecedented national crisis. Next, we're going to hear from leaders in the field representing the 9 key sectors of the health and healthcare system response, as Mike just went through on the previous slide. They're going to summarize some of the lessons learned and opportunities for further progress and improvements based on the work that they've been doing. And we'll have some discussion about that as well. Then we're very pleased to have Joanne Kenen from Politico with us to share some reflections from her perspective on the pandemic and discuss some of the implications for national transformation. Again, a good basis for further discussion. Along the way, I do want to remind you, I see where you have people starting to use it already, that Q&A button is good for asking questions for us to answer either electronically or to try to build into the discussion that we're going to have today. So with that, I'm very pleased. I think we have the Surgeon General with us now. Just checking if he's online yet. And there's that Q&A tab again. So we would be at remarks for the Surgeon General, but I can fill the time for a minute if we're having trouble getting him connected. This is one of the issues with the new era of Zoom. You can't necessarily tell when people like walk into the conference room. Maybe I will go ahead and do a brief introduction while hopefully Ariana Idola, we can make sure that we are getting Vice Admiral Adams connected properly. But just by way of introduction for the Vice Admiral, he's the 20th Surgeon General of the United States as the nation's doctor, which is what this position has become. His mission is to advance the health of the American people with the motto that better health through better partnerships is a good way to drive that. I know from prior Surgeon Generals that I've worked with that they typically have more events and talks around the country, meetings, than there are days in the year. I'm sure it's an interesting change in how to make those connections with the era of the pandemic and much more virtual contact and limits on how much actual event interaction can occur. But as you all have probably seen, the Surgeon General has been very active in public service announcements, engagements with a very wide range of communities, and working on new partnerships and strengthening existing partnerships involving business, faith, education, public safety, national security communities. The Surgeon General oversees the operations of more than 6,000 uniformed health officers who serve in nearly 800 locations around the world, promoting, protecting, and advancing the health and safety of the United States. Dr. Adams is focused on building a culture of health and prevention in all sectors. And as part of these efforts, he's compiling a report of available evidence and best practices documenting the connection between private sector investments and public policies with the goal of inspiring not only research, but providing tools, providing resources for effective community health investments, again, health in all policy areas and all community activities as a result of these new kinds of collaborations. And as Mike talked about in his opening remarks, the COVID context has both highlighted the importance and the need to build up those kinds of resources where we don't have them today, and has also launched some new opportunities for making progress in those partnerships. And let me just check back with Ariana or Idola. Do we have the Surgeon General connected yet?
Like you stated, the Surgeon General is very busy, so we are still working to get him connected, Mark.
Okay. Mike, I don't know if you want to, if we want to just pause for a moment here in the hopes that we'll get him on soon, or if there's another item that you'd like to go on to in a little bit more, a little bit of depth while we have a moment.
What we can do is move directly to the sector updates.
Okay.
And then when he's available, we can break in, because even though there's an important flow and continuity to them,
Great.
They are individually arranged, so we can have a sort of a pause at the appropriate juncture.
Okay, we'll do that. And for those of you who are involved in the sector updates, I see David on. I think we'll be starting with you. But Mike, did you want to provide a few introductory comments ahead of the updates?
No, I think we should move right ahead. I was underscoring in the course of my comments earlier the fact that the National Academy of Medicine's Leadership Consortium, of which you are all important members, is unusually well positioned to have the finger on the pulse of the challenges in each sector, and similarly well positioned because of your leadership roles, not just in your sectors, but throughout society, to have a sense of the cross-cutting implications and the notion of how we move strategically across sectors to make progress. So just with that underscoring, we can move ahead, Mark.
Okay, and actually now that you've done that introduction to the sector updates, very pleased to let you know that I do think we have Surgeon General Adams with us. Vice Admiral, or are you online?
Yes, hi, good morning. This is Lieutenant Zoe. I'm just doing the tech check real quick and making sure that you guys can all see and hear me okay. Surgeon General will be on in just a moment.
Okay, great. We definitely can hear you just fine, and I think we'll probably need Ariana stop the screen sharing if he's right. There we go. So looks like we're in good shape. So whenever you all are ready to begin, thank you. Okay, so maybe until we do get him here, we could start with the sector updates, and I'm just trying to find who is first for that. Mike,
The patients, families, and communities, I believe, and David Scorton.
Okay, great. That's actually maybe a good introduction to the Surgeon General's remarks too. So, David, do you mind starting off?
That'll be a pleasure. Thanks so much, Mark. Thanks, Dr. McGinnis and everyone to have organized this thing so well. It's incredibly important to the country, and I want to thank you for all the work you've done. In order to save time, I hope that my colleagues who are co-lead authors on this will forgive me for not enumerating everybody's name, but there was a large group of people responsible for this, and I'm just the person fronting it this morning to share. And on the documents for the overall consortium, you can see the names of the other authors, and also they will join me in thanking the incredibly effective NAM staff and helping us to get to where we are. So just a couple of slides. And the challenges related to patients, families, and communities, which of course is the main point of everything that we're doing, is what I'm going to be talking about. First of all, critical sector demographic vulnerabilities were revealed by COVID. The disparities that were not created by COVID, but were shown in bold relief, where, for one example, communities of color and indigenous communities experienced disproportionate rates of infection, hospitalization, and death rates, as well as sequelae. And very importantly, we find that patients and families and communities themselves were not enough, or frequently enough, or effectively enough included in key decision-making. Next, critical sector communication and collaboration vulnerabilities. The disparities that I just mentioned and the well-recognized lack of inclusion of community voices, patients' voices, and family voices have been factors that have contributed to a lack of trust, not only in public health, but in healthcare systems in general. And that, of course, has many, many ramifications. For example, people's willingness to adopt medical advice, even, for example, to the point of using vaccines. And there has been, unfortunately, a proliferation of misinformation or confusion on the severity of COVID, the status of testing, and treatments. Finally, on this slide, the critical sector policy vulnerabilities that we found were unequal access to adequate supports, economic supports, information supports, and so on, that sometimes fall into the category of social determinants of health. And then, of course, more specifically, insufficient access to adequate testing and to affordable treatment. This latter point is especially important since roughly half of the country gets its healthcare coverage from employer sources, and the economic downturn related to the pandemic has taken many, many people off the employment rolls and therefore off the insurance coverage rolls. If I could have the next and last slide, please. Thank you. In terms of lessons learned, the specific priorities for transformation, we believe that it's very important to have more effective engagement of patients, families, and communities in responding to this and other emergent events. And in fact, this year, as we roll out our strategic plan at the Association of American Medical Colleges, we're expanding the traditional tripartite mission of academic medicine, that is medical care, research, and education, to include community collaboration as a co-equal leg of the stool. Secondly, transformation of home and community-based services, nursing homes, reframing to better suit the needs and the desires of patients and their families. And I want to emphasize again that the way to find out about desires and needs is also to ask and include the voices of the people themselves, not only expert voices. Finally, a reduction of longstanding, really unconscionable disparities, which my generation, for example, working on this for decades, I and others did not get the job done, and we need to push harder on this now. Finally, last point, system-wide priorities for transformation. Therefore, meaningful inclusion of patients, families, and communities, that is, their voices in decision-making across all sectors of the study. And finally, of course, increased access to care and conditions that support health with or without a pandemic. So those are our findings, and I appreciate the chance to share them, Mark and Michael.
David, thanks very much for that concise summary. And we are going to go back to the Vice Admiral now. I really appreciate him joining us. And actually, this is a good introduction to his comments. But I would just add to David's remarks, we started off with this one because it is really something we intend to embed in all of the sector updates that you're going to hear about later on today. But right now, with that introduction, Vice Admiral Adams, we've already said a lot of nice things about you and all the critical work that you're doing at this uniquely challenging time. And I actually think David's comments were a good setup to some of the things that you've been working on. So thanks for joining us.
It is absolutely my pleasure to be here. Thank you so much for your patience. It's been a interesting day. My wife started cancer treatment today for a recurrence of her metastatic melanoma. And I also had keynotes this morning on tobacco control and on Recovery Month and opioid overdoses. And so you all are my last big event today before I go to meet up with her. But I want you to know that each of these things is incredibly important to me. And my wife also is someone who said, look, I've got friends here to go with me. I'm going to be fine. It's incredibly important that you are there to talk about this issue to this very important audience. And I just want you to know I'm glad to be talking to my friends at the National Academies again, albeit in a virtual manner and at a very trying time for all of us. We're tuning in today to discuss the state of healthcare, healthcare delivery, and healthcare systems as our nation grapples with a terrible new reality. Just this week, our nation passed the sobering milestone of over 200,000 lives lost to COVID-19. As many of you have heard in the news, now the third leading cause of death in the United States. SARS-CoV-2 has shaken our world to its core, and we've struggled over the past 9 months in a race to protect human life from a new and deadly adversary. Indeed, we know that COVID-19 and its sequelae have caused a level of strife and suffering unseen on our planet for over a century. As when facing any unknown adversary, we're forced to engage in, however educated they may be, trial and error guesses on how to fight back. We take lessons learned from situations that seem similar, and we try to apply them to see if anything works. But unfortunately, the reality is, when you don't know something, you just don't know. It takes time to work through the scientific process and to uncover data-validated answers, to gather and verify information about who is most at risk, how we can both prevent them from falling ill, and how to best treat and care for those who do become infected. I personally, as your Surgeon General, worry greatly about assaults from all sides on the credibility of science and on health and science practitioners and institutions. Many of the debates that you're seeing occur right now on a national level, I worry are going to have impacts decades into the future on the credibility and people's faith in long trusted institutions. And I hope you'll discuss how each of you and the National Academy of Medicine in particular can help lead a depoliticized conversation about the scientific process and help people understand that being wrong is a normal part of that process. But having the vigilance to keep looking for information that disproves what you think to be true, as well as having the humility to acknowledge it and to change course, is actually what makes a good scientist. For example, we now know that the virus, unlike its relatives, has a high degree of asymptomatic spread. We were wrong on that one, but it wasn't due to incompetence or due to nefarious intentions. It was due to, again, relying on what we knew to that point, but continuing to follow the data and to let people know when the data showed that we were wrong. We know now that the virus may spread through both large and small particles in the air, and that masks are an effective way to prevent spread between individuals. We know that patients laid on their stomach versus their backs have an easier time breathing and can recover more comfortably and more quickly. And we know that we achieve better outcomes when we delay versus hasten ventilatory support. All of these things have allowed us to decrease the number of deaths that we have actually anticipated in this country. Remember, back in March, April, there were many people, many of your organizations, many of our organizations that were concerned that we could have had millions of people dead in this country at this point. So while we need to be respectful of, cognizant of, and appropriately sorrowful for all of the lives that have lost, because one preventable life lost is too many, we need to remember that we've come incredibly far in 8 months from an average fatality rate of 30% at one point just in the past year, down to less than 5% if you get diagnosed with the virus. There's also still a lot we don't know. We still don't understand why the virus is so vicious in the bodies of some, while others won't even experience the mildest of symptoms, won't even know that they have it. And we still don't know what the best course of drug treatment is to give those who succumb so that they have the best chance of survival. We've got more options than ever, but we still need to work to improve the tool chest and also to figure out which tool to take out of the tool chest for which situation. But the most profound realization that we must now accept is that the old state of our health and healthcare systems, and especially our social infrastructure, was inadequate to sufficiently protect the health of all Americans. We all just quite simply need to own that. That is to say that as a nation, we have the obligation to care for the health and well-being of our citizens by ensuring equitable opportunities to care for one's health. But the outbreak of COVID-19 has demonstrated in stark contrast that that simply isn't the case. In the US, the COVID-19 rate of infection is 3 times higher in predominantly Black communities versus white ones, and the mortality rate is a staggering 6 times higher. What is perhaps more staggering is that even under ordinary circumstances, the life expectancy of people who live mere blocks away from each other, such as in the highly racially segregated neighborhoods of New York or Chicago or Indianapolis, can vary by over 20 years, merely by walking a few blocks. It can be tempting to chalk up some of the disheartening disparities in infection and mortality rates for COVID-19 as simply side effects of the life choices that people of color in these communities may have made. After all, these communities also tend to have higher rates of smoking, obesity, and hypertension. Perhaps these communities would not have been so hard hit by the onset of COVID-19 if they'd just taken steps to be healthier, some postulate. Well, we know that people can only make choices based on the opportunities presented to them. Or to put as I often say it, I strongly believe in personal responsibility, but I also believe the choices people make are 100% predicated on the choices that they have in front of them. Predominantly, Black and brown communities are more likely to live in food deserts and lack access to healthy, affordable foods, in addition to being more likely to lack walkable communities, making them far more likely to suffer from diabetes, hypertension, and obesity, making it far less likely that they can make healthy choices, the same healthy choices that we have when we choose to go out and take a walk, when we choose to go out and eat a salad, when we choose to engage in activities that we know are health promoting. The fact is, pre-existing medical conditions are more often than not the result of pre-existing social conditions. Now in the COVID era, mitigation measures like social distancing and telework, for instance, simply aren't available to low-income Black and brown people living in spaces that are on average smaller, more crowded, and they're less likely to be in jobs that allow them to work from home. The lion's share of people of color aren't falling ill and dying from COVID at higher rates than their white peers because they're being reckless or because they've made uninformed choices to put themselves at risk. Rather, as a society, we have created the perfect storm of conditions to disproportionately affect Black and brown folks at the hands of a pandemic because we've denied them the opportunities to build resilient communities. And that's where meetings like the one you're having today come in. Meetings of the mind among leaders, change agents from many sectors allow us, and in fact, they should force us to take a hard look at where our systems have left behind and failed too many. Meetings like this are unique opportunities to right the wrongs of systemic disenfranchisement, especially in the healthcare sector. As healthcare and medical professionals, we know more than most about the intersection between community wellness and health. We know the importance of exercise and a healthy diet, and thus access to the means of a healthy diet can have on an individual's health. The value of preventative intervention versus the much higher cost of treating an ailment down the line is something that we often talk about, but our systems aren't designed to reward wellness and prevention. They're designed to reward sickness and emergent care. We've also failed in our larger understanding and leveraging of how the American economy functions and how that can and should influence our response to disasters such as epidemics. For example, there's been a lot of debate about the failure of the federal government to stockpile personal protective equipment. Yet, at no time has the federal government ever had the capacity to procure or stockpile more than about 1% of the total personal protective equipment in circulation. The sad reality is that while some healthcare personnel were working weeks straight while walking around in reused and makeshift PPE, a few hours and sometimes just a few minutes away, there were furloughed healthcare workers and boxes of unused supplies sitting on clinic and surgery center shelves that were closed. There are certainly lessons to be learned in terms of preparedness on a federal scale. Believe me, there are also lessons to be learned about the expectation for the feds to swoop in and be saviors and mobilize the production of supplies at an unforeseen capacity overnight. The truth is, in the system we currently have, the private sector and local communities have always had a greater ability to do that in a situation that requires a nationwide response than the feds do. That's why those of you in this meeting need to be the ones driving the conversation about how we move towards more sustainable business models in our practices. Businesses that compensate for population health instead of operating on fee-for-service. Healthcare delivery models that meet people when and where they have their need instead of being an inconvenience that is pushed aside until it's too late. Looking at incorporating preparedness protocols into all of our operating practices so that we are in a better position for the next pandemic, whether it's viral or whether it's due to some other unforeseen catastrophe. And we need to look intersectionally across our industries and within our companies and organizations to address ways in which we can consider incorporating the principles of equity and prevention into the policies which impact our employees and our communities. I applaud the work of the National Academy of Medicine for spearheading this look into key sectors to address the challenges that our health systems face, but also recognizing the opportunities for improvement in value, care, delivery, and outcome. Our greatest innovations in healthcare delivery and policy in this nation and on this planet, I'd remind you, have come after wars, have come after times of terrible tragedy. Clara Barton formed the American Red Cross after the Civil War. Advancements in blood transfusion science occurred because of World War II. We saw a greater adoption of the use of antibiotics and discussions about who should and shouldn't get access to healthcare coverage after World War II. The innovation of trauma care after the Gulf Wars is something that will be saving lives far into the future. The fact is, every crisis brings opportunity for change. And shame on us if we don't capitalize on the opportunities and the lessons that are being brought to bear in the midst of COVID-19. These aren't easy conversations to have, especially as we're all admittedly suffering from pandemic fatigue. And as I often say, there's no chapter in the pandemic playbook for an impeachment trial, a presidential election, or a social justice moment that we haven't seen since the 60s. But as a community of healers, those part of the greater healthcare delivery team and tangential industries, I just want to say we have a responsibility to collectively rise above all of the politics, all of the noise. We have a collective responsibility to do better. We can and must address the underlying inequities and deficiencies that allowed COVID-19 to strike minority and underserved communities with such devastation, so that we never find ourselves so vulnerable to any sort of attack, again, viral or otherwise, ever again. It's something that I began looking at long before the onset of COVID-19, and that I want you to stay tuned because I'll examine at length in my upcoming Surgeon General's report on community health and economic prosperity. Through years of public health and medical practice, I observed that the healthiest communities were also the most profitable. No big surprise there. But I also realized that organizations that actively invested in the health and the well-being of their communities also seemed to flourish. It wasn't money thrown out simply for philanthropic purposes. It wasn't money that was just extra and given out from the goodness of their hearts. It was money that was invested and gave a return on investment. So I had my team do the research. And what became clear is that organizations and corporations that invested in their community's well-being also showed greater profitability and success. In our upcoming Surgeon General's report, we detail some of the exemplars and case studies that demonstrate how investing in community health is not just something to do as an act of social responsibility, but that it can actually pay dividends. And that's what the conversation today is really about. How can we all implement a value and science-driven health system that works in the best interest of communities, of physicians, and of stakeholders? It is possible, and the impact of COVID-19 has made its necessity more prescient than ever. So I'll just close by saying I look forward to the conversation today. I look forward to reading the outcome of your section deliberations. And if we have time, I'm happy to take a few of your questions. But thank you. Thank you for all that you're doing and for all that you've done. And just don't lose hold of this moment. Don't let it pass you by. I'm a big Hamilton fan. We can't afford to miss our shot because even though it seems COVID will never go away, the fact is we thought that about Ebola. We thought that about Zika. We thought that about H1N1. And there will come a time in the very near future that we will move on to whatever the next problem our nation and our planet faces. But shame on us if we simply look at this as a fire to be put out and don't think about how we can change what are some fundamentally broken systems, or at the very least systems where we now see we can substantially improve to make sure we're better prepared the next go round, and ideally that we prevent the next pandemic from occurring. Thank you for the opportunity, and again, happy to take some questions if we have time.
Vice Admiral, thank you very much for your remarks, but I think even more so for your heartfelt commitment to really doing something about the big challenges that you've laid out. And also special thanks to your wife. Sounds like she has an equal kind of commitment to these very important issues. And I know our thoughts and prayers are with you all as she goes through this next phase of her treatment. If you don't mind, we do have a few minutes for questions. For those of you who are panelists, if you could, I should have mentioned this before, but use that raise the hand function and we'll get to as many of you as we can. While I'm waiting for that, you did mention the report coming out, which sounds like right on target for what we need now. So the positive examples of a path forward. Are there any particular ones that you'd like to highlight that address some of the issues that you raised and that are very important for the deliberations of this group?
Well, thank you so much for that opportunity. And one of the things that I love about the conversation you're having today, again, is that it's cross-sector. So I love to tell this story. I was speaking to the U.S. Conference of Mayors. I had Mayor Benjamin on one side of Columbia, South Carolina, a little bit of a smaller city. I had Mayor de Blasio on the other side, and it was a room full of mayors. And we were talking about walkable communities because New York City and Columbia, South Carolina are two of the most walkable communities in the country. And I wanted to know what made these mayors tick. So I said, mayors, how many of you all ran for office on a pledge to lower your community's hemoglobin A1C rates by 15%? And I'm going to assume that you're all laughing because whenever I tell the story, that line brings applause. But that said, not a single mayor raised their hand. And so I said, well, why did you create walkable communities? Why are you interested in this? And they said, we created walkable communities because we know that walkable communities are safer, more foot traffic, more well-lit, less likely for people to be injured or hurt. We created walkable communities because it increases property values. It drives more business to the downtown area and more revenue, and that increases our property base. And so I make this point because as a physician, I think of a walkable community as lowering your hemoglobin A1C rate. But most of the public doesn't think like we do. They think about health they think about the economy, and they think about safety and security. And so we need to really speak in a language that resonates with people. And this report translates it. And I'll give you a very real example. Belden Industries is a wire manufacturer, global impact, global reach, but they're based in Richmond, Indiana, which is actually a small town. They were interviewing dozens of people to fill a single job because they would have the application submitted, bring them in for first interview, bring them in for second interview, hire them, and then they'd fail the drug screen and they'd have to start all over again. So what they did, not from a fundamentally health point of view, but from a business standpoint, said, we're going to screen people up front before we even have them submit their application. And if they screen positive, we will direct them into treatment through partnerships they formed with local nonprofits and with the local health department and other organizations. And if they're successful in treatment, we will save a job for them. And what they found is that the people who successfully made it through that program are their most loyal employees. They actually miss less work than people who don't have a substance use disorder. And this is an example of us learning to address the needs that people truly have out there and express, as opposed to trying to hammer them over the head with our health message when they're really worried about how am I going to pay my bills and how am I going to keep myself safe. So many more examples like that in the report. And I don't want to take time away from questions by going too much in the report, because I hopefully will work with many of you, including the national academies, to push that report out. I think COVID has really shown a light on what happens when we don't pay attention to the health of our communities and how it has an impact on our economy. But again, important for us to think about those other partners and for all of us to collectively think about the chain of stakeholders. And finally, the most important thing I would say to you is one of my favorite quotes. Many of you have heard me say it before. People need to know that you care before they care what you know. And different people have different love languages. So we need to learn the love languages of the stakeholders that we're trying to convince and speak to them in their love language, as opposed to speaking solely in ours. And that's what your meeting today is about. but that's what I would encourage you to continue to do. The faith community, the business community, the law enforcement community, they all need to be critical partners in rethinking what our new health ecosystem looks like.
Great, thank you. And we are, I know you've got other things to do. We really appreciate your taking the time. Maybe one last question. I'm going to try to consolidate from a few that have come in from our audience and participants today. You touched on some of the important things you think we need to do to move forward, get beyond the pandemic and deal with these difficult underlying issues. This is a really challenging political time, as you pointed out, just a storm of lots of different issues coming together, and you're right in the middle of this. What have you found, Vice Admiral, to be most effective for toning that down and getting back to a focus on science and public health to drive progress on these really important issues?
I love that question, and if it were easy, we'd have it figured out. But I think that one of the things we have to do, and we talk about this in regards to interactions with people of color and disadvantaged communities. We all need to acknowledge that we carry with us implicit bias, whether it's towards someone of a different color, someone of a different religion, or someone of a different political party. I think one of the first things that we can do is really explore and acknowledge our own biases that we carry with us. I'll tell you, what's been interesting is seeing many of my colleagues, and I'm very happy to see now that anytime you turn on the TV, I could turn on the TV that's behind me right now, and I guarantee you there would be a physician on one of the major news networks. That's a great thing. We're getting visibility, but there are a lot of folks out there who hate the other political party more than they hate the virus. And that's demonstrated in their actions and in their words. And I'm talking both sides. I think we need to recognize our own biases and try to take, it's not to say that you can't be political, but it's to say that it's very hard for you to be seen as an agent of science if you're out there arguing for or against one political party or person. And so I think that's important for us to acknowledge. I think the other thing we have to do, and what I try to do, is get as local as possible. I've been on the road quite a bit, even though many of you know I'm high risk. I've got high blood pressure. I'm pre-diabetic. I've got asthma. But I've been on the road most of the last several weeks because on the road, whether it's in Central Valley of California or in South Carolina or in Houston, Texas, where I'm going this weekend, I can have direct conversations with people in a way that you just can't have that conversation right now from and in Washington, D.C. and in the midst of the political climate. We need to have the courage to go to other people's tables instead of expecting them to come to ours. And finally, and I saw a question about climate change. It's another great example that I like to talk through because I think it illustrates some of the failures we've had in health communication. So one of the places that I love going to, had a conversation with them just last week, is West Virginia. West Virginia, I've been to quite a bit because of the opioid epidemic, but I will tell you, I've been to many communities in West Virginia where 50 to 75% of the community is directly or indirectly dependent on the coal mines for their livelihood. I also know that there were people who have loudly said that from a political standpoint, if they were in power, they would get rid of the coal industry, said it in no uncertain terms. And they've said that thinking that they're having a conversation about climate change. But think if you're one of those people in West Virginia who actually is dependent on the coal mines to pay their rent, to send their kids to college, to put food on the table. They're not having a conversation about climate change. They're having a conversation about their livelihoods. And that's where this failure occurs in us being able to have conversations. We're speaking in different languages. We're speaking in completely different framing. We haven't really adhered to people need to know that you care before they care what you know. Because I'll tell you, that person in West Virginia thinks that you don't give a damn about them when you go out and say, I'm going to shut down the coal mines. And they know that their granddaddy worked for the coal mine, their daddy works for the coal mine, and they're hoping to get a job at the coal mine so that they can pay their bills. We need to better illustrate the plan, the glide path to a better world for everyone. And there's a way to do that. When I have conversations about our impact on the planet, I sit down with someone as a parent. I say, wouldn't you agree that we all want to leave a world that is better for our kids than the one that was handed to us? No one of any political party is going to say no to that. Well, wouldn't you agree that there are actions that we can take in our communities that can either increase the chances that the world will be better or decrease the chances that the world will be better? And people agree on that. And then you work backwards and you say, well, what are some small things that we can do in our lives and in our communities to make that happen? And you keep working backwards and let the goal be the determinant of the conversation versus letting the political vehicle be the driver of the conversation. So probably more than what you all wanted to hear from me on this topic. I'm sure some of you disagree with me in what I said, but that's my approach. I really try to be empathetic. I really try to understand where people are coming from. I really try to get to their level and meet them where they are. And I found that in most cases, when you take that approach, people really will listen to you, and that you have way more in common with people than there is out there that separates you. And we need to find those threads that are in common, and we need to have a little bit of humility as leaders and as health professionals in particular to know and believe that we don't know it all. And even when we do know it all, that may not be what motivates people to act or to change behaviors and change policies. And if we can do that, if we can all commit to doing that, then I'm convinced that we can make a better world for everyone out there. I really hope that we'll look back, just as we've looked back at advancements in innovation in health and technology after past wars, that in 5 to 10 years, we'll look back and we will be appropriately mournful, respectful of the lives lost during this pandemic, especially those lost to COVID, but that we will also be able to say, that's the point in our history, in our nation's history, when we really got serious about fixing some of these fundamentally broken systems. And you know what? We've saved dozens, hundreds, thousands, tens of thousands more lives because of that realization. So thanks, Mark, for the opportunity. I just couldn't be more excited for the conversation you're having. I wish we could be having it in person, but I really look forward to the proceedings, and I'll be peeking in and out throughout the day and throughout the meeting because I want to learn too. So I hope you all stay safe, and I hope you get your flu shots. Get them publicly, get them as soon as possible, because this is going to be our most important flu season of the last several decades. And what's a real shame is having an intervention out there that can prevent an epidemic, that can prevent death and disease, yet knowing that less than 50% of the public and less than 40% of Black and brown people actually avail themselves of that preventative aid. So thanks, appreciate the opportunity, and I'll see you all soon.
Great. Thank you much. Thank you very much, Vice Admiral, and I appreciate your time, your effort, your empathy, and engagement with us on this. We'll look forward to continue to work with you as the National Academy work continues. And thanks for getting that last message about flu shots as well. This is got to be the toughest time ever to be a Surgeon General, not only because of all of these deep fault lines that COVID and the other stresses on our country have exposed, but also because you've got to do now an in-person and virtual job. You're probably setting the record for a number of Surgeon General appearances, and that's a pretty high number. So thanks for taking the time with us, and again, all the best wishes for your wife going forward too. Thank you.
Thank you.
All right. And Mike, I'd like to turn back to you for moderating our sector report. I think we can pick up right where we left off with maybe a little bit of discussion around the first one from David on patients, families, and communities.
Excellent. Thank you, Mark. And thanks again to Surgeon General Adams for a remarkable, passionate, and inspiring comment and charge to all of us. And I'd like to add the best wishes of the National Academy of Medicine to your wife's speedy recovery. And thank you, David, for a very nice and concise presentation. You set a great standard for all of us, and did your sector team proud. We would like to have a little bit of follow-on comment. And if I could turn to Georges Benjamin for a quick reflection on the patient, family, and community sector assessment.
Sure. Hopefully you can hear me, Mike.
Yes.
Great. Yeah. Yeah, I think that's important. You know, the whole issue around families and the challenges families are having. I think we need to really make sure that we're capturing that in a holistic way, and not and recognize that they're part of the community, and the challenges they have are, frankly, fairly complex. And so I think as we go forward, we need to just make sure we're looking at that through that lens and recognize family includes many people and many generations as part of that, as the way we look at that.
Thank you, Georges. Do we have other comments from the Leadership Consortium that folks might want to make before we move to the next session? I realize we're a little bit behind, but I don't want to short shrift what, as Mark indicated, is our ultimate target for improvement.
Hi, Mike. This is Frederick.
Thank you, Frederick.
You bet. I just wanted to mention as one of the co-authors that, and a very big thank you to David. He did a wonderful job, as always. He's a terrific co-author. That we're very conscious of a couple things. I think there's a real passion within the group to make sure that health equity is a central focus of the discussion and the inequities that we're seeing, a really important moment for the country. And also trying to build linkages between this report and the impact on patients, families, and communities with the other insights that are coming from across the sector. So we're trying to make sure that there's a strong signal coming out of national academies that draws a link between the impact on people and the observations and insights occurring within the sector.
Thank you, Frederick. You've reinforced two of the fundamental charges to each of the sector groups, and that is one, to look specifically at the issue of equity and how it's playing out within the sector. And the second is to look across sectors at ways for synergy and looking at how we can loop back to ensure that we're addressing the system-wide possibilities. I think then in the interest of time, we'll move on. We're going to try to set up some time for the end of the sector presentations. If necessary, we may have to encroach a little bit into our executive session because we want to make sure that we're doing full justice to each of the sector presentations. And next up, I believe, we've had a little change in the schedule. It's health payers. And Mark, I don't have the latest word on whether you or Rahul is going to do the presentation here. I know Rahul was juggling a challenge.
Yeah, I think it's me, and not that people haven't heard enough from me already today, but Rahul Rajkumar is the co-lead of this sector effort around payers, and I want to thank him for all the work that he's put in. I think he's dealing with some urgent payer issues that come right out of this report right now, so he apologizes for not being here. Let me highlight first the challenges that this group has identified, and this is sort of the payer perspective on exactly the same challenges that we've already been hearing about, including from that great preceding presentation from David and colleagues. First and foremost, it is obvious that the sector has real vulnerabilities. They were there before. They've just been highlighted in the pandemic when there was this big change in utilization caused by the pandemic. There were several things going on early on. One was uncertainty and concerns about utilization going up due to issues related to COVID-19 treatment and management and potential complications. And as we saw those big declines in utilization, as fewer people went to get the care, including the care that they really needed, concerns that there might be a rebound with future trends going back up, leading to a lot of uncertainty facing payers about how exactly they should be planning for this unprecedented public health emergency. We've also seen some shifts in enrollment, something like 3 million plus individuals losing coverage at this point, and a significant shift into Medicaid and people moving out from their job-based coverage, maybe into a COBRA coverage or something like that. So some challenges in the mix of patients and impacts on revenues and projections for that reason as well. And this was all when payers needed to take new steps to ensure access to care and stabilize revenues for providers, especially many smaller practices, but really lots of, really entire sector was one of the hardest hit in our economy in the spring and heading into the summer. So those were all areas where payers had to respond quickly. New kinds of payment models, financial assistance, relief for some of their members who were struggling with premiums and the like. Another set of challenges related to responding to the pandemic through needed data sharing and collaboration, getting data on patients when they're not coming into the office, relying on virtual telehealth and other technologies to do that, sharing data with public health authorities around new outbreaks and learning about their patients who had actually tested positive was not easy to do with health information systems that were not well integrated. And new collaborations were also needed to deal with changes in practice, not just scaling up telehealth visits, but really developing models of care delivery that recognize that people were going to need to get more services at home or in settings that put them at less risk, both from their own perspective of confidence and safety, and also from the need to treat people in different circumstances as well. So responding to all of those shifts in sites of service, bringing in new kinds of providers, telehealth across state lines, all that was supported by payer responses to make payments more flexible and support these kinds of new models, but very hard to stand up for many healthcare organizations and the payers working with them in the setting of this urgent public health emergency. And that revealed a lot of challenges that need to be addressed both for this pandemic and going forward. To pick up on the Surgeon General's theme, the financing of care remains very fragmented and very reliant on fee-for-service. Essentially, the healthcare organizations that were relying on fee-for-service payment were the hardest hit in the pandemic. And so at a time when, you'll hear about this from the provider groups coming later, the time when we really needed their assistance around responding and implementing these new models, many of them were just worried about staying open or minimizing the amount of staff that they needed to lay off. And since many of the fee-for-service payments had been dependent on in-person care, as not to mention fragmented care, didn't lend itself well to the kinds of care responses that were needed in the pandemic. So in terms of responses, as on the next slide, the group identified a number of priorities within the sector as they're trying to take steps to make care more efficient and effective at a time when we really need to manage costs in a tough economic setting for the businesses, the individuals, and the public sector paying for healthcare, finding ways to not restart some of the care that stopped. So many services that are needed, like immunizations, many of the preventive services that the Surgeon General mentioned, are still not coming back fully. A lot of elective procedures have to a larger extent, but still many gaps. If we're going to redirect resources to focus on those needed services, services to the extent we can direct them away from low value services. That can be very helpful. There have been some publications, and this group is going to include some of those specific examples in its report, finding ways to treat problems that involve low value care historically with better ways of managing issues like back pain, headaches, and other types of conditions that have led to excess costs and low value. And then really making telehealth a more central part of healthcare going forward, not just by paying for visits, but by supporting more integrated models of virtual care that build in remote monitoring, that use longitudinal data to help support those telehealth visits, that identify where telehealth can really substitute and virtual care can really substitute effectively for alternative models of care. And this is not just in enhanced primary care, not just in enhanced access to behavioral integrated care as well, but also in specialized areas of care, moving end-stage renal disease care more into the community setting through peritoneal dialysis and less reliance on dialysis in facilities, or moving cancer care or care for other advanced illnesses, chemotherapy, drug administration, other support services into the home rather than institutions, which can be not only more convenient and safer for patients, but also lower cost as well. Critical to all this is accelerating the movement into value-based care. The healthcare organizations that have been most resilient in the pandemic so far are the ones who were already far away from fee-for-service payments, relying more on patient or population, so-called advanced alternative payment models. They already had some of these data systems, telehealth and other programs in place, and it's renewed the commitment on the part of payers to spread those models, maybe working across the public and private sector more effectively on payment reforms, and changing benefits to align benefits with these better care models, so that when we can deliver better care, especially for vulnerable populations and those that have been most affected by the pandemic, it should cost less for them as well, not the traditional structure of copays and out-of-pocket payments related to fee-for-service utilization, but really more related to value and helping people engage in these new models of care as well. So a lot more to cover there, but let me stop, Mike, and open it up for discussion.
Thank you, Mark. And thanks to the whole team, which I know is firing on all pistons, and you've crammed a lot into a short period of time. May we turn to Peter Long from Blue Shield of California to offer a reflection?
I'll be super brief. Hi, Michael. Hi, Mark. Hi, everyone. I would just say two things. One is the piece that there are lots of heroic efforts from payers across the country that we'll document in the paper. I think the real question for this group is, what should we continue of those heroic efforts and they made sense and worked, versus they happened despite the infrastructure that was set up against us, right? Or that was set up in a way that didn't facilitate that. So I think that's the fundamental set of issues that Mark raised, was not, there's a great recounting, I think, of wonderful efforts to rise up to the challenges. The question for us as a group, not just on this paper, but overall, is what are the things, and that's what Mark raised, is what are the things structurally that we would want to change such that we don't require heroicism? It builds on the Surgeon General's efforts. So I'm allowed here, I will leave it at that and turn it back to the group. But I think that's our fundamental question, is where does heroicism make sense, and where do we need structural changes as we move forward?
Thank you very much, Peter. And if there's anybody else from the consortium who wants to leap in with one more follow-up, please do. I'm not very skilled at picking on people, but if the first one to the microphone can have it. Okay. Well, again,
Michael?
thanks. Yes.
Yeah, hi, it's Lee Fleischer, now from CMS. I'm curious, what kind of data do you think we need to help make these decisions about where the future should, what the future should look like, and how fast, even being inside CMS, do you think we can get to that data?
critical question. Mark, you want to give a quick response on
Yeah,
that?
just a quick response. And Lee, we're very glad to have you at CMS to partner in these efforts. What came up in the group discussion was a desire to really link payments more to quality, to equity, to the goal, exactly the goals we've been talking about today, but the challenges in doing so, both in terms of the measures that are available and in terms of getting alignment across our multi-payer system and moving in the same direction. So I think the report will have some recommendations related to that, and we'll look forward to working with you to refine those and hopefully get them into action.
Thank you, Mark, and thanks to each. As we move to the next session, let me offer a couple of transitional comments that we would have made at the outset but didn't. The first one is to introduce Dr. Valerie Montgomery Rice, who is the president and dean of Morehouse School of Medicine, who is also a recent, as of yesterday, new member of the Leadership Consortium. Many of you know Valerie. Valerie, if you're on visual, wave your hand. And I also like to put in a plug, maybe if you can be thinking about giving a quick response to our next presentation on clinicians and professional societies. After that presentation, we'll come back to you. But again, a hearty welcome to you, and thanks so much for joining us. The second comment I wanted to make as we move to clinicians and professional societies is related to the questions that are being raised during the course of the presentations. We will be, obviously, since we're moving very quickly of necessity through the presentations, we can't catch any but a fraction of the issues that are raised, and they're all very important and insightful. So we'll be collecting those, triaging them to the various sector groups for engagement in the follow-up. It's important to emphasize in that respect that what you're getting is a status report at this point of work that is in progress and is about at the midway point in terms of the overall progress. So thanks again. Let's then move to our next sector report, which is from Clinicians and Professionalist Societies. And speaking on behalf of that group, presenting is Suzanne Miyamoto, who's the head of the AAN. Suzanne?
Well, thank you, Mark, and thank you, Dr. McGinnis, Dr. McClellan, for your leadership of the consortium. I have the distinct and wonderful opportunity to work with Dr. Jim Madeira and his colleague, Dr. Mira Irons, on this particular topic related to the clinicians and the professional societies. And our authors, as you know, have a wide expertise across the professions, both on community health, infectious diseases, ethics, looking at critical care, and obviously the health professions, of course. And I wanted to say thank you to the incredible NAM staff who have been able to support us through our thinking and this process. I think one of the things that the Surgeon General hit upon, and the synergies across our discussion so far, was really this discussion around the sobering realities of COVID-19 and the impact on communities. And I think one of the things that struck me when he was speaking about the impact on communities and health equities, but also our role as clinicians to build those resilient communities. And I think as we dived into the content around the impact for clinicians and professional societies and supporting clinicians throughout their work, there was a range of issues. And one of the things that really came up in the vulnerabilities, as we've seen time and time again, is the impact on the clinical those in a clinical setting, as well in other settings across the disciplines, with their impact on moral distress and moral injury, and how that is impacting their ability to provide care. and the very quick and swift, significant transitions that had to be made during clinical care, thinking about the movement to different work environments, being pulled from one work environment to a new environment where some of those changes were needed or the demand was needed, or as alluded to earlier, some of the layoffs that had to occur because of the dynamics that were occurring within the larger healthcare system. And the complexity of that was, as noted in the slide, the lack of data standardization and interoperability, and the ability to transmit that information quickly to clinicians, whether it be in the acute care setting, out in the community, and being able to receive clear, consistent communication in real time. And I think one of the other pieces that was really incredibly important in our discussions to date have been that effective communication piece, but also looking at it from the perspective of the public health work environment and the public health workforce. And I think one of the things that we know about the public health infrastructure, the public health workforce, is the significant investments lost over the years with the investments at the federal and state levels, and the impact that that has, as the Surgeon General talked about, on vulnerable populations and the sharp inequities that arose from it. I think the Trust for America's Health did some work looking at how many positions were lost from 2008 to 2017, and over 55,000 positions were lost in those local health departments. And how does that impact the ability in a pandemic to get the information out to the communities that we serve? And so we think about all of those factors and looking at the stress that it causes on the system. As we think about those opportunities on the next slide, we really have some opportunities to look at both as important, on the next slide, that we want to be thinking about is the transformation around looking at those models. And one of the things that, as many of us know, the National Academy has really led on is the Action Collaborative on Clinician Wellbeing and Resilience, and looking at how those models and what has worked in a non-pandemic elevates and needs to be elevated in this pandemic and beyond. And I think those challenges are going to give us some insights and the imperatives that we're going to be needing to move forward. I think the other piece that we're going to have to be looking at for the clinicians and the professional societies is also, as mentioned before, telehealth. Telehealth was stood up very quickly, incredibly quickly, and how can this continue to be maximized where it is having a really great return on investment to access and to be able to make sure that patients and communities, and how can we support providers in their ability to continue that telehealth, but also some of the policy changes that will need to occur because of the challenges with telehealth, and how can we continue some of the great work that has been occurring already to make sure clinicians have that readily available access to telehealth. I think the other thing that Dr. McGinnis stated so eloquently earlier was COVID-19 was the perfect storm of system fragilities. And I think the other piece, as we look at that within the clinician sector, is the educational infrastructure. In real time, health profession schools were having to shift and change and think about new strategies. Some professions were having challenges getting clinical sites, some were moving into the clinical setting, and really how do we communicate and bolster that, that training and that workforce so that they are able to move forward in the pandemic. We know part of this is so critically important is that interprofessional teams and those interdisciplinary teams, and how do we use this opportunity to reinforce the team model in making sure our patients receive the best care. I think, at the end of the day, one of the other pieces that we really highlighted upon was the pandemic further highlights the need for us as clinicians to be thinking about and advancing, just as the Surgeon General mentioned in his remarks, was prevention, primary care, and the change to those prevention policies. So a lot of the work is really thinking about how to continue to make sure our clinicians are ready. So with that, I will pause there. I know Dr. Madera is on the line, and I know Dr. Montgomery Rice is going to offer some reflections, but we are really looking forward to the opportunity to hearing more from the Leadership Consortium.
Thank you very much, Suzanne. Jim, did you want to add anything to Suzanne's wonderful presentation?
No, I think it was just hit all the points. In the interest of time, I think we can just move to the reflection of Valerie.
Thank you. Valerie?
I am here. I had to cut off my video because I kept being disconnected. So thank you for allowing me to provide some reflection. And I would say Suzanne did a very comprehensive look. And what I would add to it is that what I think we can do as professional societies is ask ourselves, what are the resources we need to provide to our clinicians and our providers for strengthening their resilience and grit? I think we all were really challenged early on with the pandemic, and different on the setting and what city you were having in was how challenged they were with things that I think we had taken for granted, and the amount of resilience and grit that we saw each of those healthcare providers really exhibiting in light of the challenges that they were faced. So I think as professional societies, we need to be on the preventive arm of that, please, really, for helping to make sure that we're supporting our providers in that way. And then I think we also need to recognize that there are definitely differences that exist depending on where you are. And again, trying to get ahead of where those differences exist based on the geographical locations where people are. So those will be my comments.
Thank you, Valerie, and thanks once again for your joining us. We're so privileged to have you with us. Before we move on to the next topic, anybody want to add a brief comment from the Leadership Consortium membership? Okay, then let's move to care delivery organizations. Jeff Balzer, who is the president and CEO of Vanderbilt University Medical Center, is going to present.
Thank you, Mike, and my thanks to everyone. And I also want to thank my co-lead, Jaewon Ryu from Geisinger. This is really a team effort. We have a number of wonderful co-authors that are assisting us. The main challenges I want to highlight are, first of all, we all know that health systems had a remarkable drop in care volumes, mostly during the months of March and April, but that persists even now for some healthcare systems. And while that had a financial impact that a number of people have talked about and will talk about, there's also an aspect of it that we really do need to get our arms around as an industry, and that's this term elective care, which frankly is so misunderstood. Many people think that it just means optional care like cosmetic surgery, and others used it to mandate a complete cessation of anything except emergency care. And what we really need by health elective is just scheduled. It could be, urgent elective care. So I think that the term elective was a big problem for the public, for the healthcare provider industry, for all the sectors. And we really need to get around some standard definitions so that as we deal with volume changes that could occur in the future, we have a better understanding of how to manage those and communicate them. Another challenge, and this is a communication and collaboration challenge, is how to work together during a pandemic. And that was a challenge across health systems, managing large populations together for the first time, as well as coordination within health systems. So across healthcare systems, most municipalities have systems where there are 2 or 3 or maybe a dozen different owned healthcare companies to a large degree in competition with one another. And suddenly we found ourselves in a situation where we really needed to work together to support the overall pandemic. And while I think in almost all cases, folks were willing to do that, what we really need is some pre-wired standards and reflexes around how we will triage patients and how we will triage resources during these kinds of circumstances. So we're not all trying to figure that out and negotiate it in the middle of a crisis. I would also say that within health systems, the fragmentation within health systems really became much more visible during the crisis. So if you've seen one health system, you've seen one health system. There are those that are completely consolidated under one single governance, including all the clinicians and providers like mine. And then there are those that are very fragmented, where physicians are working at hospitals from many different companies. And in some cases in academic medicine, the practice plan is separately owned from the hospital. And during a crisis, those became challenges as well. So again, having some pre-understood plans and protocols for managing through all that within health systems, we feel would be very helpful. Another issue is that most of the emergency preparedness we have done has been really focused on anticipating events that are short in duration, such as a tornado that wipes out part of a hospital or a shooter incident, those kinds of things where it's awful, but it's short duration. This is obviously very long duration, and we are finding that much of our emergency preparedness really didn't focus on that kind of eventuality, and something we need to really think about and work hard on. Another challenge that we saw and are continuing to see is how to improve surge capacity, specifically in critical care. It was a challenge to manage surge capacity in less acute settings and within medical and surgical floors, but it was an even bigger challenge to manage surge capacity in ICU settings. And so there's a staffing aspect to that. There's also actually a supply chain aspect to that, and many of the systems we've talked with feel that aspects of the nation's healthcare system supply chain really ought to be treated much more as critical national infrastructure, such as the ventilator shortage that we saw. And then physical infrastructure in hospitals, designing hospital rooms so that they can flip between ICU care and non-ICU care, so that the gases and all the things we need to rapidly flex into more ICU capability are built into the nation's healthcare infrastructure, would be a very important upgrade that our country could and should invest in. Finally, financial reform. And there, I think what we're looking for is something that gives us sustainability in a situation where there's a sudden change in revenue. We certainly don't want healthcare systems unable to make payroll, and that's not only bad for the healthcare systems, but it's bad for patients. So we need a reimbursement system, in addition to having it be more value-based, but also one that assures a fairly constant revenue stream through a crisis. And we need, again, pre-existing regulations that would allow that to occur, so that we're not trying to work through that with dozens and dozens of different sources of revenue that we all deal with in healthcare systems. Those are some of the highlights. Of course, there were many others, but I'd be happy to take questions or other comments.
Thank you very much, Jeff. And again, thanks to the team as well. Reed Tuckson, would you mind offering a brief reflection on what you've heard?
Sorry for that. Thank you very much. And I think the real key to this has been that as our health systems respond to this crisis, it is telling us that there will be a change in what happens going forward, that we're going to have to be very and very considerate about the community-based preparation and those community linkages between the delivery systems and the communities that surround them, to really create something of a true shared vision and collaboration so that we can increase community-based resiliency and to be able to manage these concerns going forward. Secondly, I'm particularly interested in how well we will be able to deal with the economics of preparation downstream. What will be the supply chain implications here for the future? And especially as we start to bring things in home versus just-in-time dependency on more international systems. What will be the economic consequences of that? And what will be the economic consequences going forward on redundancy, perhaps in bed capacity? As we've worked so hard to take waste out of the system, and we now try to right-size that and have some redundancy built in, the question will be is how does that get financed? And so I think these are two elements, what the external looking community relationship and the internal focus to try to be able to have flexibility and resiliency on the internal side of operations. But how do you do that in a way that doesn't already change the unsustainable relationship of unit cost escalation associated with the delivery? These are the challenges that I think that we are really going to have to stare down. And if we don't put those squarely in front of us now, we will be way behind come post-COVID.
Thank you very much, Reed. We're going to have a little change in the schedule because of scheduling challenges, and we're going to go next to the health product manufacturers and innovators. Before we do that, are there any other comments for the healthcare organization group from the members of the consortium?
Hey, Mike, John Perlin here.
Hey, John.
Hey, good afternoon, everybody. I thought Jeff's overview was just absolutely terrific. You know, from a perspective of the health system that has now cared for over 60,000 COVID positive inpatients, I think Jeff clearly hit all the right features. I just want to put an asterisk and amplify on the need for facile data. Whether it's facile data from our government in terms of prediction and better modeling at the local level, you know, to say this is the rate of COVID in Tennessee is very different in what's going on in rural Tennessee from what be going on in Nashville, for example. And the data then also need to flow across the components of the health system. And clearly we still have continuing interoperability challenges in terms of the formal care delivery. But something that I think was really pressed this time was the lack of adequate connectivity with the health departments. And it's really at the junction of the health data, the ability to assess some of the social determinants and the merge with some of the formal health system data that I think we'd be able to be better prepared to meet community needs and certainly, heaven forbid, meet the next pandemic. That said, we have so much opportunity at that fragile interface already that I think it speaks to the need for further work there. Thanks.
Thank you very much, John. That issue, or the set of issues in particular, the last one, has come up several times, and we'll return to it in just a few minutes. But let's first now turn to the health product manufacturers and innovators. And presenting as a co-lead for the sector work is Vas Narasimhan, who's the CEO of Novartis. Vas?
Yeah, I'm here, Mike. Thanks for the opportunity, and I appreciate being able to move up a bit in the schedule. I'm here in Europe. Just as a brief introduction, I'm CEO of Novartis. I also co-chair the Gates Foundation CEO initiative on COVID response. Also a member of the academies. I'm here to represent Mathai Mamin, the head of R&D at Johnson & Johnson, as well as Adam Schechter from LabCorp, Rick Kunz from Medtronic, Mojda Paul from 3M, as well as a few other members. And we've done our best to try to reflect the various parts of the health product manufacturers. Of course, a broad spectrum of participants in this part of the industry. But what we've tried to do is divide into the core areas: pharmaceuticals, vaccines, medical devices, and health products. So in terms of critical sector capacity vulnerabilities, and it's a pretty consistent theme in our discussions, First is capacity constraints early on in the pandemic, especially in the early days, given that in most of our supply chains, it takes a few months in order to really scale up, whether that's in drugs or in critical supplies for ICUs, or whether that's medical products. And of course, you all know well the story around ventilators. There is a lead time associated with capacity scale up. And then there's of course global demand considerations that add additional complexity. The second key sector constraint vulnerability we had identified was around global supply chains, and how international trade, depending on the month, was disrupted in various directions. Overall, I think it's a consistent theme. We believe having global supply chains with adequate redundancy enables us to meet the demands in the United States and other countries. However, the fact that politics often plays an incredibly important role in international trade, there is the possibility for significant disruption. So that was kind of the critical capacity vulnerabilities we identified early on. In terms of communication and collaboration vulnerabilities, there was quite a bit of discussion on data collection and sharing across sectors, so that there was a good understanding of what would be the demand for various products and services from our collective industries. In terms of also understanding how those would shift over time, I think understandably there's a lot of uncertainty early on in a pandemic, but I think that was one area of improvement. And then I think in terms of unclear communication and alignment on what are the needs at the federal and state government, this was particularly on the medical supplies as well as device side, but understanding what would be the needs from individual manufacturers, because the demand comes up in an extremely fragmented way. It's certainly a challenge for those manufacturers to be able to appropriately scale and then provide the products that are needed. In terms of policy vulnerabilities, and these are topics, I was heavily involved in the H1N1 pandemic response on the vaccine side in 2009. So these are not new learnings, but the need for warm capacity in manufacturing, and to the extent possible, warm capacity for relevant stockpiles. I think that happened in the past. It typically wanes after a few years after pandemic, and then we have a pandemic and we learn again. If you go back in history, back to 2001-3, if you look at the H5N7 avian influenza, and then of course H1N1, we have this kind of recurring theme. And then obviously the insufficient research and development. I mean, right in the early days, you're focused almost entirely on repurposing vaccines and repurposing drugs, and of course getting to a vaccine. It's interesting, there was almost no real sustained effort on trying to find from the early days of the first coronavirus, SARS-CoV coronavirus emergence almost 20 years ago. There was no effort around that. If we had done those efforts, perhaps we would have an oral drug much quicker, which would of course provide a lot of ability to scale very rapidly versus the various biologics we're currently pursuing. If you go to the next slide. In terms of some of the opportunities we've identified, like many of the other sectors, clearly digital and analytics have enabled us to support clinical trials with remote monitoring of patient visits and enabling us to monitor patients from a distance, and also improve our patient support programs, HCP interactions. You've seen, of course, explosion of telehealth services. That's a clear opportunity, a huge acceleration. The ability to get from study concept sheet to study startup within 6 weeks is historically unheard of in our industry, and yet we've been doing it now consistently over the last months. And then I think there is an opportunity for strengthened collaboration on data sharing and standardization of data collection. I think on the one hand, it's been impressive to see the explosion of interest in conducting studies by parties of all types around the world. I think maybe 10,000 studies now around the world, and the range of different drugs and vaccines and diagnostics that are all in clinical development. But our ability to standardize protocols, standardize data sharing, and do this in a thoughtful way so that we get the patients into the right trials with the appropriate rigor that can actually inform decision-making either by regulators or relevant clinical bodies is clearly something that can be improved. And we still, even at this moment, don't have a great method for data sharing across the sector. And then in terms of priorities for transformation, again, I don't think anything particularly new. The importance of domestic coordination and in strengthening international bodies that can provide us as an industry appropriate guidance. If you look today, there is still no international body that provides standards or guidance in terms of distribution of vaccines and drugs and diagnostics or medical supplies. It's largely done bilaterally across countries, also bilaterally with the United States. That creates, of course, inequities, particularly for poorer countries. That's obviously an opportunity, I think, to improve. And then the importance of cross-border collaboration in terms of supply chains, particularly, again, on the medical products and medical devices side of things. Those supply chain disruptions lead to significant disruptions for the ability to get what's needed to local hospitals, local community health centers in their time of need. So I'll stop there and then hand it back to you, Mike. Thanks.
Thank you very much, Vas. Really appreciate your leadership, both to our work in the National Academy of Medicine and to your broader role in the global health arena. And I'd like to ask John Perlin if he could offer a brief reflection on Vas's and the team's presentation.
Well, let me thank you for terrific comments. I think the points you made resonated very clearly with a member of an organization that lived that side of supply chain. I think this is really a unique opportunity. It brings into question some of the fragilities of supply chain, ranging from just-in-time inventory to geo-concentration, as well as the economic incentives of what's manufactured and developing pipeline. On the more promising side, as you indicate, thinking about your comments and other commentators, research is really accelerated. And we have the opportunity to use our data systems to learn at scale. And I would hope that in that vein, the capacity to really create development, not only of pharmaceuticals, vaccines, but also mechanisms for scaling of manufacturing and expedition of distribution would be some of the other sort of structural learnings that are important as well. Finally, the last comment is that I think it's incumbent upon all of us in association with this set of activities to really help contribute to the general understanding, appreciation, and education around the importance of expertise. I think the potential for some of this development to fall prey to misinformation or ambiguity is just too real at the moment. And I think the uptake for both support for development, investment in the science necessary for development, as well, frankly, as the utilization of the products of development, it really demands almost an intense a public service approach to improving an understanding of science and expertise. And I think that also suggests an important role for the Academy. So thanks for your terrific comments, and thank you, Michael.
Thank you, John. I believe we have Mathai also with us, who co-lead with Vas on this. Mathai, do you want to, can we call on you to make a couple of additional comments?
For Michael, and Vas actually summarized the various contributors' perspectives really well. And maybe what I would add is that each of the contributors were asked to not only reflect on COVID-19 and what we would do the next time around, but really talk about the broader biopharmaceutical ecosystem, product manufacturers ecosystem in total, to address some systemic issues that kind of plague all of it, not just pandemics of the future. And so I think that's something that when our paper is complete, the readers can look forward to. But thank you very much.
No, thank you, and thank you for underscoring that dimension. And I know a number of the comments that are coming in, questions coming in, are addressing that broader issue, and we'll triage them to you as you work to enhance that dimension. But again, thanks to all of you on the team, and Vas, thanks for making time in your European circadian rhythm. Very good of you.
Thank you.
Let's move now to the digital health arena. This is an issue that has been touched on in every single sector assessment, and obviously is a vitally important dimension for any transformative enterprise across the board. Representing the co-leads here are Peter Lee, who is Corporate VP of Research at Microsoft, and Amy Abernethy, who is the first Deputy Commissioner of the Food and Drug Administration. And Peter, I believe you're going to do the presentation.
Hi, thank you, Michael. I think Amy will get us kicked off here.
Oh,
and then we'll
good.
go,
Amy.
short tag team.
Like I said, Amy, you're going to kick us off.
We're doing our tag team. And so first, I'll start by reviewing the vulnerabilities and what does this tell us about the future, and then turn to my colleague, Peter Lee. And I just want to step back for a moment and say that as this book of work got going, the language of digital health suggested that this sector analysis was going to focus on tools and technologies such as what we've heard about with respect to telemedicine and the role of telemedicine in the remote management of patients, as well as remote monitoring clinical trials. But in fact, as we step back and thought about the key vulnerabilities identified, what we really see is that this is around digital infrastructure, especially the data ecosystem, and how important that is to then be able to enable all the different types of change identified. And in fact, what we've heard over and over again is the need for data and solutions through data is very important here. And so I highlight several elements in the vulnerabilities. First of all, with respect to data-related capacity, especially on the public health data ecosystem side, where we have very antiquated systems and transmission of test results, as an example, by fax machine. The antiquated system is very antiquated on public health, but we also see lack of interoperability within the electronic health record side, also causing challenges, and then issues related to cybersecurity risk is also highlighted as a key vulnerability here. There's also issues as it relates to coordination across the many different actors and actors who hold data that are going to be important to solve for the public health crisis, and also the lack of ability to interoperate as well as be able to support sharing across systems and data retrieval. And then finally, on the policy side, not only is this around data governance and data sharing, but also key vulnerabilities as it relates to being able to utilize data in order to support agile clinical trial models, hybrid trials, real world evidence, and the such. Next slide, please. And so, how might we transform? Certainly, priorities for transformation focus on data as our first stop. So standardization and harmonization, the ability to share and have a governance framework about how do we, in the space of a pandemic, put that into action quickly, and how do we also ensure that our data infrastructure supports the ability to take care of all of our populations, including those who are most vulnerable, through the inclusion of key information that will help us take better care of everyone. The other issue certainly is the ability to have a data infrastructure that supports the use of real-world data of all types to answer the many questions of public health, clinical evidence development, and other priorities across the system. Other key priorities that we've highlighted and continue to work on exist within the clinical trial infrastructure, as well as in the digital infrastructure as it relates to many of the capabilities we've discussed, such as the role of telehealth and continuing to push that forward. These are the aspects we're going to be working on within the digital health sector. And as you can see, data sort of is the underlying kind of substrate of this part of the story. I turn it over to Peter Lee at Microsoft to add his commentary.
Yeah, thanks, Amy. I think in the crisis response, we saw huge disruptions in so many different sectors. And the amount of coordination and collaboration that was enabled by data in shipping and logistics, manufacturing, financial services, retail and commerce, even software development was pretty remarkable. And yet, as we are seeing in every single sector assessment in this National Academy's effort, in healthcare, we seem to have found ourselves flying blind and with the inability to have appropriate coordination and coordinated response, despite the fact that healthcare in the US and in the world has undergone tremendous advances in digitization. And so all of the promise of that coordination, of the insight, being able to do predictive analytics seem to fall short. And so as Amy had just described, we've zoomed in on specific issues, and that has given us a way to focus our attention on how we might do better, not only for this ongoing crisis, but for future ones. And I think understanding those exact points of frustration, which are being brought up over and over again across the various sectors, is basically the way that we've been trying to organize our thoughts.
Thank you, Peter and Amy, again, for leading a very productive assessment process, and we look forward to the follow-on, and we really appreciate the perspective of ensuring that we're tending first to the infrastructure that's necessary to enable the progress that is possible. Let me turn to, for comment, to Judy Faulkner, our colleague on the consortium, who is the CEO of EPIC. Judy?
Sure. I agree that some of those basics are really critical. Without standardization, interoperability just can't happen. There's not much sense in sending data over that the other side can't understand what it is anyway. So first of all, people have to get together and standardize. And I think the other thing is that, at least with our health systems, help some of them who don't have the wherewithal to install the software that will allow them to interoperate, because I think there's a lot of critical access hospitals, hospitals in rural areas that really, even if the software is there, they might not have the help and the financial ability to install and support it.
Thank you, Judy. Are there other comments from the group or from members of the consortium?
Yeah, Mike, this is Reed. And as you know, Jonathan Perlin and I co-chair the Digital Learning Collaborative. And one of the things that I want everyone to be aware of with your leadership, Mike, is trying to develop indicators that will tell us how well we are doing across the board, particularly in the degree to which information is being available and used by clinicians to change the way they support and support their care decision, and the way in which individually generated health data is integrated into the learning health system. And finally, the percentage of digital health tools that are being used that are being supported by evidence. The point that we're trying to get at here is, I think what you will see in short order is coming forward will be these indicators that will help make sure that we have a way to track progress in these key areas. And I think this is one of the most important things coming up. It's not enough just to have these ideas out there. We have to make sure that we are incorporating them and have some sense of the progress, or unfortunately, where in those cases, lack of it, getting this done.
Thank you, Reed, and thanks also to you and John both for chairing the Digital Health Action Collaborative. More to come on that count later on. Let's then move again in the spirit of the calendar and the clock to our next presentation. The last couple of conversations have been a terrific setup for that. State and local public health, and the co-leads for the sector assessment are Karen DeSalvo and Bob Hughes. Karen is the Chief Health Officer at Google, and I believe is going to do the honors today, right?
I sure am, Mike. Hi, everybody. Great to be here. Happy to be here representing our work group, including Bob Moffat, who's my co-lead for the chapter. We have some great folks that are co-authors of this group. Georges Benjamin, who's on, Mary Bassett, Nadine Gracia, Jeff Howard, Sandra Galea, and Mike Frazier. So we have people who have worked on the front lines, including myself, in local and state and federal public health, and have a really good trajectory of the history of this field. Very much appreciate also the National Academy of Medicine team who has helped us to begin to crystallize the ideas. I think the timing of this is even aside from the pandemic, helpful, given that the public health community in the U.S. has been on a trajectory the last few years to think about how to create a 21st century model that leverages new types of relationships and data and approaches to the work that can more strategically and collectively address the public health challenges. There's been an acceleration of some of that work, even in the last few months from public health. So we're hoping to build upon that energy and thinking from the public health community directly of what they know they want to do for transformation, and how the pandemic has really highlighted the need to accelerate some of that work. The challenges include that there are some sector capacity vulnerabilities that have been revealed because of the pandemic, sometimes on the front page of the newspaper or in our Twitter feeds, things like the lack of investment in just basic infrastructure and workforce to be able to do what they need to do every day, much less in a crisis. Workforces, anything from epidemiologists all the way through to having contact tracers available at the ready on the front lines. That also there's been a fragmentation of the public health system to further distance it from not only the medical care system, but even some partners that seem likely very important, like the preparedness infrastructure that happens at the national, state, and local level, where sometimes those teams are not planning in collaboration and acting in collaboration in times of crisis. And that we plan to highlight that there's also been a large gap in social care infrastructure and funding and general resourcing that's led to an increased role for public health in this pandemic to try to address the needs of communities writ large, especially vulnerable communities, but also working to address the social needs of people who need to be isolated because they're COVID positive. That there are some sector communication and collaboration vulnerabilities that have been highlighted. We've just spent some time talking about digital infrastructure. This is not unknown to the public health community, and they've been wanting some upgrades, but also some modernization for better interoperability in between the public health infrastructure, say for lab reporting, but also across sectors to improve opportunities for surveillance with electronic systems in places like the healthcare infrastructure, and also need workforce have workforce vulnerabilities to modernize some of the talents and capabilities. Certainly, any strained system struggles to to effectively engage with Black and Brown communities as well as other vulnerable communities, and I think making sure that those vulnerabilities don't get exacerbated following the pandemic was a priority for our group so far. And then I think some discussion that we hope to play out about the need for understanding some of the policy vulnerabilities that have played out, where there's not perhaps as much of a directive federal response in a national crisis that might give some clarity to especially small local health departments who need to be able to move swiftly. Next slide. Some of the things we are working on in terms of lessons learned fall into those big categories about sector-specific priorities for transformation, including building upon the recently released 10 essential public health functions. This is an update of what has been described in the past about modernizing the mandate for public health at the local and state level, linking that to an accreditation process and to funding for a sufficient workforce and infrastructure and other systems that can enable that work to be done in a way that meets the public health needs of everybody in the U.S., irrespective of their geography or the color of their skin. To significantly improve the surveillance and monitoring systems, including linkages to novel data sources or novel signals from social media or from EHR systems, as well as just broadly modernizing the digital infrastructure for areas like laboratory and e-case reporting. And then some opportunities for system-wide priorities for transformation that can enable and support better opportunities to address the needs of vulnerable populations, marginalized populations who may not have access to the traditional medical or even other health systems that might be in place, and then creating more clear linkages, particularly in the public health and emergency management systems at all levels of government, so that there's clarity about ownership and responsibility and accountability for addressing pandemics, but also smaller crises that happen in the everyday. So I'll pause there and be happy to take questions or hear any feedback from the group. Thank you, guys.
Thank you very much, Karen. May we turn to Julie Gerberdine for an initial comment? Julie, you may have had to drop off. I know she had a time constraint. If she's able to come on before we move on, let me then ask if Bob Hughes, if you'd like to underscore any particular point, or if there are other questions or comments from consortium members.
Sure, thanks, Mike. I'll just say, I think the public health sector, it's come up in several of the earlier summaries, which I think points to the fact that among the sectors, it perhaps is leading the pack in terms of could use a fundamental transformation. And I think one of the challenges really is in moving towards that kind of change. Not only having it be in the financing mechanisms, but also in the underlying structure of the public health relationships among the agencies, particularly between the state and local agencies. I think one other point I'd highlight is that in the sort of conflicts that have flared in communities across and in response to the pandemic, and how communities have responded to it, local public health officials are really on the front lines, and they have often been in the middle of the controversies and have really been under some personal attacks. And there's been some serious consideration about the safety of some of our public health officials. So I just think it's worth noting that the inadequacies of the way we have responded have really played out often in disagreements at the local level that have really put local public health officials right in the middle of those controversies.
Thank you very much, Bob. Let's then move to our next sector presentation as we move to the last two. And next up is health and biomedical research, in which the co-leads are Nikayla Cook, who's the executive director of PCORI, and Mike Lauer is the deputy director of NIH. And Kayla, welcome to the consortium, and thank you very much for your leadership.
Thanks so much, Mike, and thanks for the opportunity. I'm glad to be here, and I'm happy to present on behalf of myself and co-lead Mike Lauer, who's just been a privilege to work with him, and thank him for his contributions to the summary. So as we've been talking about through most of the morning, that the health and biomedical research sector just is no exception to a lot of the broad sweeping challenges that have been discussed related to COVID-19. And there are a lot of lessons that we are learning with implications perhaps even beyond the pandemic. And some of the challenges that we've identified are really around trying to effectively generate valid evidence and research results in response to the pandemic, and that the pandemic itself has exacerbated some pre-existing stressors, particularly as we look at the research workforce. And some of these stressors related to the workforce are probably most evident amongst our early career investigators and those who are underrepresented in science and are disproportionately, I think, affected in their participation in research worsened in the setting of the pandemic. And there are a lot of uncertainties around quantifying these effects right now, but some of the early data are showing that women are posting fewer preprints, for example, or publishing fewer papers. And thought leaders actually are worried about whatever progress we've made in terms of enhancing the biomedical workforce diversity, that we have the opportunity to lose some of that in the setting of this pandemic. We also recognize that the public has really looked to the scientific enterprise in ways never done before in terms of how to accomplish what some might have even thought was near impossible, almost instantaneously trying to explain what's happening and develop some safe and effective cures and vaccines even within months. And so the research processes that we typically utilize to stand up studies have been challenged to do this more rapidly, stand up clinical studies and associated infrastructure to translate research into practice across all sectors of the health system, and balance this concept of rigor with speed, which I think has been an incredible challenge during the pandemic. There's also been critical sector communication and collaboration vulnerabilities, and some of these relate to the imperative now more than ever for communication and coordination and collaboration across researchers and funders and across sectors, as well as building public trust in science and validated research findings. And even prior to the pandemic, there had been a lot of efforts to promote data sharing and build interoperability across data sets, which were gathering momentum, even though we know that these efforts were challenged by technology hesitancies of sharing, as well as validated research findings that had the ability to be shared across when there were challenges of standardization, et cetera. But there's really a heightened urgency and a new challenge in this pandemic for data sharing and interoperability for research that's been spurred on by the pandemic, with several needs to deliver actionable, more real-time research results that can be built upon by the entire scientific community, as well as independently replicated. There have also been challenges to promote interoperable clinical systems data that can support identifying even the basics like outbreaks and tracking mortality rates, but also utilizing, as Dr. Abernathy mentioned earlier, real-world data to promote the delivery of best patient care in the midst of the pandemic. And we recognize that there are opportunities as well and challenges for this in terms of supporting data governance and infrastructure that will help us to stand up trustworthy data repositories for the type of research that's needed in the pandemic. Other vulnerabilities, especially around policy, relate to this paradox that we've been talking about for the research community that's trying to respond to COVID-19, really necessitating an engagement of communities that are most adversely affected and those that may have some of the greatest distrust of the research enterprise. And thus this emphasizes that challenge and need to build and establish meaningful partnerships with communities as research partners or incentives to build them. Next slide. There are also have been, maybe there's one slide missing, I'll just speak to it. There have also been several lessons learned in terms of thinking about the critical sector-specific priorities for transformation. And some of this relates to the fact that the biomedical research enterprise now really has an opportunity out of necessity to guide transformation that will help build long-term resilience and diversity for the research workforce. And some of the opportunities here may be to bring diverse research personnel into the front lines of the type of clinical trials and research that's happening in the pandemic to engage more robustly with diverse patient populations and communities. There is also, I think, a phenomenal lesson for us in terms of understanding how to adapt new and innovative funding mechanisms and processes that can help accelerate the research that is necessary to be conducted in this pandemic and translate into some accelerated findings and results and potentially even ultimately outcomes. And we also recognize an opportunity or a lesson learned for an opportunity to coordinate across research projects, both internationally and nationally, and learn from some of the activities that are being stood up across the globe that can help accelerate progress and deliver on some longstanding efforts even related to data sharing and interoperability. And maybe the last point related to lessons learned is around this opportunity to elevate communities and participants as equal partners in research while engaging the public in science in a way that can enhance that understanding of the scientific enterprise. So with that, maybe I'll pause and see if there are any comments or questions about several of the points that we are seeing both now in the pandemic and opportunities for the future.
Thank you very much, Nikayla, to both you and Mike for a very concise and insightful set of observations. And thanks also for your being so nimble and being able to engage the issues without the second slide. On that count, I should note to folks that all the slides will be available afterwards, even though I have to underscore that, bear in mind, this is a work in progress. Mm-hmm. May I turn to Jim Madera for a brief comment on the health and biomedical research arena?
Sure. Thank you, Michael. And that was really wonderfully insightful. Thank you, Nikayla. And I guess I would think about a couple of different reflections. We talked about communications, and one of the aspects of that is not only communications in the stakeholders, but communications with the general public. The Surgeon General raised that issue. And one general thought in biomedicine is to have the public better understand the scientific method. I do have to say, I'm told by my social science friends that that's the wrong approach, and that Americans are busy with their families and work, and they don't really care about the details of the scientific method. What they want is our trustworthy sources to provide the bottom line of what should be known. And to do that, their suggestion is one has to segregate that function of communications of science in a trustworthy way to trusted scientific sources. That would include National Academy. But once the speaker becomes a politician, whatever the issue is, it becomes politicized immediately. A subcomponent of that conversation is the type of language. So these folks remind me that there's a big difference between saying X is the preferred approach versus saying that we're in the learning phase, but based on the best current available evidence, X is the best approach. And that would get us out of maybe some of the soup that we were in March and April. The second observation is around data and studies. There were observational sort of studies that were useful. The pronation recognition came from that. However, in the rapid development of RCTs, it was harder to do in the context of the stress and chaos of the moment. So, how do we do that? And how do we include not just large sites with early enrollment in RCTs and such situations, but sites that are non-large with differing populations that might be reflective of more real world like data. Another data issue is how we follow up on what's happening. It appears that many of patients that have been affected by COVID will end up having an unpredictable range of a more severe chronic disease. And so the pressure on, the ability to get longitudinal data, the pressure on being able to incorporate remote data, and social determinants of health that are going to be important in this area are all going to be important to think about. And, as a friend once said to me, it reflects on something Judy Faulkner said just a moment ago. The problem with healthcare standards for any specific element is that there are so many of them. And we have to get to a point where that no longer exists. And lastly, building on some things that we've heard in virtually every presentation and that Reed Tuckson alluded to, is the need for resilience and surge capacity. Jeff also talked about that, and Reed mentioned the problem of the fiscal question of how you build that excess capacity. But I think another somewhat different issue is how do you retain the flexibility that you build that's likely to have some marginal ongoing cost in these extended periods between crises. So a good example of that is, we did build additional public health capacity and fund it during the H1N1 crisis. But over the next decade, that was whittled away. And so how do we retain that? And that makes me also think of the Bloomberg School analysis of pandemic responsiveness in 2019, when it was noted that the US is relatively weak in testing crisis systems periodically. Actually, one thing I would add is in talking to my biomedical bench research friends, they were also very affected by COVID. That non-COVID related bench research really went down for some period of time. And this involved everything from the appropriate husbanding of precious genetically modified animals to keeping processes alive for cell culture models, as opposed to having them, transitioned into a low temperature nap for some period of time and then rebuild. That's another issue that I think we will face in the next year.
Thank you very much, Jim, and thank you, Nikhil, again for the spearheading the important work here. And I know that as we transition to the last one, I just want to make reference to the fact that I know Rich Platt and Rick Kuntz, who are the co-chairs of our Evidence Mobilization Action Collaborative, are taking close notes and also will profit immensely, not only from the observations, but from the questions that come in. So thanks again. Let's move then to the final presentation of the Quality and Safety and Standards Organizations, which is co-led by Carolyn Clancy, who's leads the relevant activities at the Veterans Health Administration and former head of AHRQ. And she works with Kate Goodrich, who's now at Humana, and was previously the chief medical officer at the Centers for CMS. So Carolyn?
Thank you so much, Michael. Let me just say I have really enjoyed so many of the conversations today, and can also recognize the importance of the Academy's leadership in trying to bring these together, because there are so many cross-cutting and overlapping themes. I don't think it's a secret to any of you that the space known as quality, safety, and standards organizations is a rich, robust, sometimes noisy patchwork quilt of state and federal groups, nonprofits, and so forth, as well as research organizations, but really motivated and inspired by two landmark reports from the national academies, namely To Err is Human and Crossing the Quality Chasm. It's fair to say in the past 20 years, there's been a fair amount of progress, particularly in reducing healthcare associated infections, in being far more attentive to multiple aspects of patient safety, and certainly being sensitive, which is different than being, I think, effective with respect to disparities in care and the importance of social determinants, but starting to get some traction in those areas. And then the pandemic hit. And it was pretty clear in terms of vulnerabilities that the system, such as it is, which is actually a broad array of pretty decentralized healthcare systems, which are highly variable in size and serve very different populations, really was not terribly agile in adapting to new best practices, particularly during public health emergencies. And actually building on something that Jeff Balser remarked earlier, I will say VA is really, really good at short-term public health emergencies. I mean, we've got people everywhere. We're often the people backing up HHS, providing care to people who have nothing to do with our healthcare system. And we've got equipment, and all our facilities can run for a couple of weeks because we've got backups and the whole 9 yards. But an ongoing many months long and very unclear end in sight public health emergency is a very, very different order of business. That said, something the Surgeon General said I just wanted to add about rapid learning and how much we have learned in times of crisis, and he specifically mentioned military incursions, reminded me of another series of, I think, academy workshops, if not full reports, on the rapid learning that took place during our experiences in Iraq and Afghanistan, where the military made very rapid changes in how we provided healthcare to people who were wounded on the battlefield. So, you know, seeing an old MASH rerun on TV is an incredible anachronism for how people who are injured on the battlefield are treated now. And it strikes me that that might be a sort of set of very important lessons to learn from. I would say that we have no lack of safety standards. Enforcement would be a different question for vulnerable settings, particularly nursing homes, which I think is a tragedy that very few people saw coming, and I think many people have been quite horrified by. Historically, it's always seemed to me that we were highly willing at the drop of a dime to add more regulations to a nursing home mix. And yet what we found across the country was both for state veterans homes, which are not under our direct control, but are still part of that same ecosystem, and for community or private sector nursing homes, there were very, very important gaps in care. And I do just want to acknowledge the work of some of my nursing colleagues here who've done a lot of outreach, and many have been deployed for multiple weeks to various organizations. In terms of communication and collaboration vulnerabilities, to say that we've seen a huge hit to public trust in the safety and quality following the death toll in nursing homes, I think is an understatement. I think it's hard not to miss, or hard to miss rather, that we actually didn't have incredibly good advice or recommendations or systems to help people in assisted living facilities and other kinds of arrangements where many of the elderly have chosen to live some of their final days. And I think that has to be very much squarely on the agenda as well. And we've also seen a fragmentation of resources and data systems to track and monitor outcomes. Now, Mark remarked that when he was talking about the challenges facing health payers, that those payers that were not so reliant on fee-for-service tended to be those that could continue sort of a value-based approach and were best positioned to emerge from this in a very strong position. And I can't possibly disagree with that, but I would have to guess that many of those same payers also have multiple sites of care where the data streams are interconnected, which makes a very, very big difference. Having telehealth and other virtual encounters that don't go anywhere or connect to anything is fine for, like, right now, this very moment, this particular need, but it doesn't actually help us learn. And it's unclear how where patients are left confused between where I used to get care and advice and, you know, this other person I'm connected to now. Some of the other vulnerabilities. We've been very fond of saying in the past few years that there's been a rapid movement to value-based care and away for fee-for-service. Some of that aspirational. It is really hard, particularly for people on the earlier parts of the adoption curve for value-based arrangements who are suddenly hit with a very big drop in revenue. To let that fall off the radar or for it not to get that much attention. After all, if you have to furlough or lay off employees, that's going to, particularly at a time when there's a very tough economy, that's going to be front and center of everyone's attention rather than are we still working on this new bundled payment arrangement. And in terms of data and measures to identify lapses, a couple that stand out for me, I think we still have a great deal to learn about people who didn't come in for care. Understandably, they're afraid. We hear that from veterans all the time. And I've seen some payers, Humana might actually be one of them. I'm not advertising or endorsing them, but I did see an article where they were mailing people Cologuard kits and I think blood pressure cuffs or something along those lines. And I know a lot of organizations are leaning forward now for flu immunizations and the like, but we're way behind on kids immunizations, all kinds of preventive care. I'm understanding in the private sector that because of the increased requirement for homeschooling in many communities, that many mammography facilities are now open extended hours both days of the weekend because you know in many cases who's doing a lot of the homeschooling. But we need a much, much better handle on that. And it's also clear from our own system that we saw a lot fewer hospitalizations from March through May. I think we also have opportunities to learn a great deal more about staffing capabilities and tracking across facilities. It was a surprise to me that even New York State had very little idea of what kinds of staffing needs that many of their hospitals needed. So it made me feel all the more inspired by people who just found their way to New York, because I had no idea who was going to tell them you really need to go over here. And in the end, particularly looking at nursing homes, I think that we need to get much smarter about assessing capability. And some of that, in thinking about public health emergencies in general and this pandemic in particular, is really about having regular quality improvement drills. I don't mean tabletops where someone shows a PowerPoint presentation and everyone says, wow, that sounds really awful, I hope it doesn't come here. I mean really going through pretty extensive simulation exercises. And I don't think that's just limited to healthcare. I think that's got to be healthcare with other components of public health. And so quality improvement approaches really need to be part of standard protocols for emergencies. So in terms of system-wide priorities for transformation, yes, we need smarter metrics. That is like a given in every quality conversation. I think the new thing here would be a lot more information, both about virtual care and frankly, outpatient care. We don't know very much. A whole lot of care prior to the pandemic has moved out of hospitals to ambulatory settings. And it's very, very hard to know in any systematic way what the quality or safety of that care is. Clearly, issues related to worker safety arguably have not received the attention they deserve, particularly in this pandemic. It's really, I mean, you've got the perfect storm, right? Falling revenues, a just-in-time approach to inventory, people afraid of losing their jobs, but also afraid that the mask that they're wearing that they really kind of sort of think is leaking now needs to be replaced and no one's got one for them. So that's clearly got to be a big part of our agenda going forward. And clearly, based on some far more insightful comments from some of my colleagues, being on top of the issues related to evaluating and remediating disparities, which in my view is in not just cutting the quality measures and stratifying them. That's very helpful and is a useful indicator, but it also has to be far more in-depth attention to social circumstances and the like. So thank you for the opportunity, Michael, and frankly, for all the presentations I heard prior to this.
Thank you very much, Carolyn. In the interest of time, we're going to have to forego the comments here, but we'll have plenty of time over the next month or so to offer additional comments and encourage them along the way. As I turn this back over to Mark for our wrap-up session, I want to again thank each one of our presenters on behalf of who've presented on behalf of an extraordinary set of sector team members. And the watchword here is, besides thank you, is to be continued. Mark, over to you.
Great, thank you very much. Thanks all for a great discussion. I wish we had more time for comments, but I really appreciate all the comments and questions that have come in the Q&A. We have tried to bring together a diverse set of perspectives, as you've heard, and that, by the way, includes nurses and other allied health professionals who have been tremendously important in the response to the pandemic, not to mention the path forward from here to a more effective and person-centered healthcare system and better health. So we are going to incorporate all of that into the further work, and I hope you'll stay tuned as these papers move forward and we come out of this pandemic in hopefully much better shape with a more resilient healthcare system. We do want to spend some time now on another perspective on implications for health system transformation. And as I mentioned earlier, very pleased to be joined by Joanne Kenen, Executive Healthcare Editor of Politico. Joanne has a tremendous amount of experience in all of these issues, and she's going to reflect a bit on the implications of what we're living through now, some of the topics that we've heard about today for healthcare transformation in the United States. And I think some personal perspectives that she's had from not only participating in the event today and working on these issues in the pandemic, but a long career on health and issues related to well-being. She has been involved in reporting since arriving in Washington in 1994, and just reading from Joanne's bio, covered everything from Haitian voodoo festivals to U.S. presidential campaigns. Joanne, maybe you comment on which one you'd rather be covering right now at this point in the process. She's been at Politico since September 2011, previously working at Reuters and a number of locations, and also as a Kaiser Family Foundation Media Fellow, and working and blogging about health policy at the nonpartisan New America Foundation along the way too. Her works appeared in a very wide range of publications, including The Atlantic, Kaiser Health News, the Washington Post, the Center for Public Integrity, Health Affairs, AARP's magazine, the National Journal, Slate, many others. I could go on for a while. Joanne, thanks for being with us today.
I'm going to try to be fairly brief because I think you are running behind schedule, and you want to have time for discussion. I will say that as I talked to Mark and Michael this week about what you wanted me to bring to this cyber table, I jotted down notes on pieces of paper as I sort of went about my business. And last night I pulled the piece of paper to sit down and pull it together. And I saw that it said chicken, salmon, and Granny Smith. So that is what happens after you end your day. I have to watch, part of my job is to watch President Trump's daily press conferences, and yesterday's was quite a doozy. He both threatened to veto, which is why I couldn't tell the difference between last week's shopping list and what I wanted to say today. He both threatened to override FDA safety guidance for vaccines, and he did not, as you all saw from today's headlines, he did not commit to a peaceful transition this fall. He was asked several times to make sure he understood the question. And if you don't actually watch those briefings occasionally, I mean, I get paid to do it. I think it's quite informative to just sit down one night and watch from start to finish. But when I began to, I guess when I was thinking about two things here. One are what are the opportunities? And as I listened to you today, and I did sit through all of it, I think the word opportunity isn't the right word. I think the word is imperatives. That we have reached a point where we have to do the things that all of you know need to be done. Some of the things that went wrong in this pandemic were completely predictable, and some of them shocked us. It is much worse, I think, than anyone expected. I mean, none of us thought it was going to be a quick and easy pandemic by definition, but I think we are at a point where looking ahead at what's facing us in this fall and winter, forget the politics, just sort of where the epidemic is, where it's spreading, how fast it's spreading, how ill-equipped we still are for what is likely to be another surge. Yes, some things are better, and a lot of things we're just not there yet. And it is not. Those of you who know me, I'm a pretty upbeat person, and I am actually really very worried about what this country is going to be experiencing. Maybe because some of you have told me to worry, but I think it's pretty bleak. So we have opportunities that I'm going to talk about, and then another theme that's come up today. And while we were talking, the National Academy of Science, the National Academy of Medicine put out a release that some of you may have seen in your phones about the politicization of science and how damaging it is. I don't think that's a very common thing for the academies to do, but we are living through a multifaceted crisis of trust. We are awash in distrust in every, in ways such as the experiences of some of the beleaguered public health people, local public health people, which was also alluded to. I just didn't think we would be at a point where public health people would need bodyguards, where Tony Fauci gets death threats. When I speak about healthcare, I often speak about how, I'm usually talking about pre-pandemic. I was talking about Obamacare and Medicare and healthcare politics, and that healthcare had become a proxy for our politics. And even in a highly politicized, fragmented period, it was disproportionate. Healthcare was more political than other domestic issues. If I knew how you felt about Obamacare, I knew how you vote, pretty much, with very few exceptions. And I'm used to the politicization of healthcare. It's what I do for a living. I mean, in Politico, I have an army that reports to me, or an armada or something or other. I mean, there's like 20 healthcare reporters and the national staff and another 7 or 8 in the States. But I never expected, did I expect to ever confront a pandemic? Yeah, we all knew that was possible. Did I expect that a pandemic would become politicized to this extent, the way Obamacare is? No, I did not. And I think most of you are surprised by it too. That we are at a point where a mask is a symbol of tyranny instead of a symbol of our common humanity and how we as a society should be taking care of one another. So, that's sort of how I think about what's next. And I think about the landscape as a pretty disturbing landscape. But I also still believe in possibility. And I believe that everybody who signed on for 3 more, soul-sucking hours of Zoom, you're here because you already know what you need to do. Some of the things that were brought up today were highlighted by the pandemic. Some of the supply line issues, some of the surge capacity, some of the research issues, they're more short-term. They're more things we've confronted in the last few months. But a lot of the larger issues you already knew, and you've been working for them. I mean, you're not ignoring them. And there are many obstacles, including political obstacles and K Street obstacles and system inertia obstacles and not knowing how to form alliance or move ahead obstacles. But you knew, I mean, you all knew, you know, volume and the volume value conversation, or whether you call it the quality quantity conversation, you've been having it for a decade now. Or care coordination, primary care, the importance of primary care, the need for when I talk about like the need for a medical home, a primary care setting, I'm not endorsing a specific payment model or whose medical home is better. I'm not talking about in the technical sense, but the way a human being going to the doctor needs to experience it. That you have someone who takes care of you and has a full picture of you and knows what you want. Things like advanced care planning would just be part of what we do. Care coordination would just be part of what we do. It shouldn't be an idyllic, unachievable goal. It should be something that we just get. Clearly, the lack of capacity for public health, you know, it surged after 9/11. We got better at it for a while. You know, Senator Frist at those days and Senator Kennedy were really smart in passing a bioterror bill, which all of you know was also a basic public health bill. Gains were made, and then it was defunded or funding slowed down and things deteriorated again, and we were just not prepared. So that's certainly going to be a priority when we get through this, to restore, to put primary care front and center, to put prevention front and center, and to rebuild public health, or take the rebuilding we've done and make it permanent, because we are really, really good as a nation of forgetting things fast. We had a chance, someone else referred to it, we had SARS 20 years ago. We knew there were corona. I'm not a science person. I am a policy person, right? I knew there were coronaviruses out there waiting to get us. And I knew that people were working on vaccines 20 years ago and they got dropped. So that urgency of making this, oh, we're through that, bye, you know, to make that has to be a priority for every one of you. Not, I mean, the payment and this changing incentives, which we have started. Many of you are already working on them. You know, I said to Mark the other day, it was like, we've gone from islands to archipelagos of sort of quality and new payment reforms. We don't have a landmass, you know, we're still isolated. We've taken steps, but we haven't transformed the system. So a lot of you who have been working in this space, because you wouldn't be here if you weren't working in this space, you really have to figure out how to act, which is what I was really asked to end with, or open up to you. How do you start making changes? Some of the things that we have experienced, you know, we knew there were disparities. We knew there were social determinants of health issues, but I don't think many of us were prepared for the gap to be well, maybe those of us who are white and don't experience weren't prepared. Maybe the communities that we're experiencing are not so surprised. But that clearly has to be front and center of everything you think about. And the way we cover the news is also, I mean, it's not that we ignored those issues before, but we're thinking about them in a more urgent way and absorbing them into everything we write, as opposed to just, oh, let's do a story on disparities this week. But also those of us who are health literate, and those of us who do have good insurance, and those of us who are privileged in this system to some degree. I mean, I'm not Bill Gates, but I have decent insurance. But we also, I mean, all of you, if I could see you all on my screen now, and I ask you all to raise your hands, if you have been able to get the care that a loved one needed at a critical time, a lot of you would just burst into tears, because our system has, it's really unreliable and it's really uneven. So how do we take this sort of a wreckage? And one of the issues is how do we build trust? How do we create trust? Because the distrust is permeating absolutely everything. And I tell you that as a card-carrying member of the fake news, right? I am subjected to threats. My colleagues who aren't editors, who are out more visibly, are subjected to more threats. You know, we are discredited, we are attacked, we are called liars, we are called tools, we are called a lot of unprintable things. We have more security than we had in our prior existence. It's really, you know, if you go into journalism, you know, we make mistakes, you complain about us, but we're sort of a funny mix of cynicism and idealism. You know, I could have made a lot more money on Wall Street, and I believe in what I do, but now I'm an enemy of the people, right? And that's a really frightening thing when half of our country believes that. But it's you as doctors and nurses and researchers are not immune. You know, there's, from the patient that you say, you don't really need this thing you heard about from your, your golf buddy or your PTA, you don't need that. Your patient isn't hearing, oh, I don't need it, that's good. They're hearing, oh, I really need it, but the insurance company isn't letting my doctor give it to me. So you have that sort of micro distrust. You have, I'm not saying it happens all the time, but it happens. You have the larger distrust in science. We have damage. I mean, the CDC and the FDA, we're not gonna, it's gonna take a while for them they made some, there have been mistakes that were mistakes. I have been surprised. I did not expect testing to be the mess it was in this country. And that was, some of that was mistakes. It wasn't all politics. But the country is going to have less faith, which is why I think the Academy put out those statements today. There's going to have to be a lot of trust rebuilding, and it's going to have to be coming from people partnering across political lines. How do you, Michael asked me, how do you create trust? How do you create partnerships? If any of you have the ability to go really big, you find a partner in your community and do something big and bold, and you think it can work, you're really sure it can work, go ahead, be big and bold. But I think a lot of what we have to do is going to be very small. And I think it has to be finding someone who is not a normal partner or a typical partner, or in the healthcare system, because we also have to break down those silos and find something small. The example I came in here with, having talked to Mark this week, and I've been in North Carolina several times in the last few years, and I've done a lot of reporting on what Mandy Cohen is trying to do there. She doesn't call it social determinants, she calls it healthy opportunities, which is a way better term. There are some things that are unique to Carolina in the way that sort of the public and private sectors lined up, and a lot of what they were doing got stuck in Obamacare politics and has not moved ahead. But when I went down there and I heard that Mandy, who is not from North Carolina, Secretary of Health in the state, and worked in the Obama administration and worked on Obamacare and was coming down with this really ambitious change agenda on social determinants and Medicaid and poverty and silo busting, and that she had bipartisan support. I first was very skeptical that she had bipartisan support until I talked to Republicans who she had bipartisan support. And she found ways of speaking, not lying, but emphasizing different words and different messages to build support. So to talk to someone who was more of the, squishier side about social determinants is the right thing to do, she could talk to them about that sort of moral imperative and the healthcare imperative, but she could also say, and you know what, good economic sense. And then she could go to the Republicans and say, you get really good ROI out of this, and it's also the right thing to do. And she built coalitions that way. And listening to the Surgeon General today, something he said really struck me as the same kind of opportunity of where you can find language that'll, two sets of language that are both true, but you can make them merge and move ahead. When he was talking about walkable cities, and that mayors had done it for economic reasons, for property values, to boost shopping districts and things like that, and they weren't thinking about heart disease or diabetes. Doesn't matter. You in the healthcare system could go find some real estate developers and talk about, it's going to be really good for your property values to make it walkable, and by the way, we're going to help prevent diabetes. So I don't, I'm not in your community or your institution, but I just think that, some of these small trust building, unlikely partnership, cross sector is going to be the way to go. And I also just don't think we can, I don't know what the political environment is going to be. I don't know who's going to win the election. I don't know who's going to respect the results of the election. I don't know what the Senate's going to be like, but I do think that there are changes in our society that we don't even understand yet. Just like I think that we individually don't understand what the experience of going through this is for us as we sit in our homes month after month. I think there will be things that were impossible politically might become possible in terms of rethinking things that we just took for granted as in Washington releases, you can't do that. Maybe now you can. Are vested interests still going to be vested interests? Yes. Does it matter who wins this election? What are your choices going to be in changing healthcare? Yes. It's not my job to endorse anybody, but you all know that you'll have two very different scenarios. But whatever that scenario is, whether you can act on a national stage or whether you're acting at the sidewalk in your community stage, I don't think we have any time to waste. When I began talking about the pandemic in our 9 a.m. meetings, you know, it's a very political newsroom. It's Politico, right? I mean, they like me, they respect me, but they listen to me. But you know, they were focused on, you know, impeachment and the primaries and single payer and everything. And I'm like talking about this virus in China. And you know, of course, you know, I often do turn out to be right. And we all went home. I said, I don't know when we're going to see each other again. They all looked at me like, oh, there she goes again. And I've gotten so many messages from people saying, wow, you were right. And what I tell them was, no, I was wrong. You think I was Cassandra, and I think I was Pollyanna. It is so much worse than I thought it would be. And we have so much more work to do than I thought we would have. But I also, you know, all the things you talked about today wasn't new to me, but it fit together, and you created this agenda. And now you've got to go out and fix it fast.
Well, thanks, Joanne, for those heartfelt comments, and I really appreciate the point about taking some practical steps.
Today. Okay.
Yeah, there is still a lot happening in North Carolina too. Now, if you look at the agenda, we are running a little bit over. It's been a great discussion. I want to continue it for a few minutes more. We should wrap up in 10 or less, but I would like to turn to a first comment for this section to Bill Novelli. Bill is currently at Business for Impact at Georgetown, but Bill is also someone with a tremendous amount of experience in communication with the public and with building trust. So Bill, thoughts?
I'm hearing Bill.
Mm-hmm. Yeah, Bill, I think you're
sorry about that.
There
you can hear me now. Mark, thank you so much. And Joanne, hello, and thank you for that. Michael, this has been a terrific day, just a terrific learning experience. I want to go back, as Joanne did, to the Surgeon General. And I thought that he gave us a good challenge. He said, what can we learn and what can we fix? And then when he talked about social determinants and the incredibly disproportionate risk that people of color have from COVID, I mean, that hit home, and a lot of people talked about that as well. You know, Joanne talked about the need to put primary care and prevention front and center. And it seems to me that with all that was discussed today, in terms of what we can learn and what we can fix, we have got to do that. We've got to put prevention back on the national agenda. And it's easy for prevention to fall off. And I don't mean little small pieces of prevention. I'm talking about at scale. Ahmed Parikh, who was at HHS and is now at the Bipartisan Policy Center, did a book on prevention and policy. And he said, why do we keep underinvesting in prevention? Why do we keep missing the boat in prevention? And he gave 3 examples. He said, number 1, it's funded by discretionary spending, and that's easy to cut. And number 2, Congress has a lot on its plate, and they're not always up to speed on prevention. And number 3, he said, it's really hard to engage the public in prevention. We all know this. You know, as Anand said, they're all waiting for a pill. They all want that pill. They don't want to do the hard parts of what it takes to be healthy. And I think he's got a good point there. And if we're going to do anything about social determinants of health, if we're going to fix the big problems, we've got to really focus on prevention. And I'm not just talking about low-income people, people of color. Look at vaping. Vaping is a suburban problem. These are upscale kids. And look at people not coming in for care. This is everybody. So I really learned a lot today, and I appreciated it very much. And I hope that we can take on board what Surgeon General Adams said, what everybody else said, Carolyn Clancy and everyone else, and Joanne as well. and really figure out how we can make things better going forward. Thank you, Mark.
Thank you, Bill. So it's been a full discussion. I would guess to add myself, this just got the note about prevention is really, we've had a lot of failures in dealing with issues upstream in the pandemic, whether it's preventing the spread of cases by having better, more resilient places to live and work environments, or helping, as Joanne said, getting public understanding and trust around issues like mask use. So I think your point about prevention also applies in the context of the pandemic as well. We do have a few minutes for, this is such an important topic. I know we're running over, but a few minutes for comments if any of our other panelists have anything that they would like to add.
I would just also say that we have to think about prevention bigger than we used to think about it, right? It's not just getting a cholesterol test. It's not just, having your mammogram, which we could fight about whether you need one and when. It's really thinking about the social determinants and thinking about it as what the Surgeon General said, those are the pre-existing conditions were the socially pre-existing conditions. When we think about prevention, it's thinking about it in a much bigger way. That sidewalk is part of prevention.
And Joanne, I would add, you talked about North Carolina. Those efforts around moving to value and building trust have been unquestionably influenced by what's happened here during the pandemic, but it's still there. And I think the more, as you say, that we can focus on some actual practical steps, like how do we improve testing access, looking ahead to issues with the vaccine, where it's going to depend on trust, and where if in these local environments, it's easier to explain that there isn't just a process that can easily be disrupted for how companies with independent oversight do large-scale clinical trials, how they're reviewed, how FDA regulates. Sure, it'd be helpful for FDA to have even more guidance out there about what they're looking for with their gold standard of review, but they're going to apply it. So a lot of opportunities when we get beyond just the sound bites and some of this political context to have that discussion. I do think it's still a challenge to raise that level of dialogue that is so essential for transparency and trust into our political context. I don't know if you have any further thoughts on ways that we can better work with your reporters who are inclined to focus on the most inflammatory statements that tend to drive in this political
some more than others.
Attention. Yeah, how we can better work with you.
Yeah. Well, actually, I had one. If anyone, you can find my email online, or I'll stick it in the chat. This is sort of a narrow thing, but we've launched a couple of new products, all of which are free. They're not pro products. And one of the things we've started on is something called Future Pulse, and we're looking at the intersection of health and technology. And there's just so much garbage out there, right? I mean, there's really innovative things, and then there's just all this hype. And I would just love for people to email me and say, this is the thing this is real, and this is just another bright and shiny object, and you should not waste your time on it. I mean, that's what we do, is sort of chase bright and shiny objects as journalists. And then, I often think that social determinants is one of the few that stayed. It had begun to penetrate the healthcare system and how people thought of things, and then the pandemic sort of changed the subject, but they're related.
Thank
so,
you.
Michael,
in terms of, yeah, go ahead.
I think we had time for one more question. Was there, I think there was maybe one.
I have a comment and a question. First of all, I want to thank Joanne for her comments and providing a dose of reality into this conversation. In the conversation, I also appreciate all the comments that we've heard today. It does strike me that this is a potential agenda item for the National Academy to think about how to rehabilitate the scientific opinion in this country, and to help recreate the trust that we once had in CDC and FDA. Rather than simply noting the loss that the damage done to those organizations has created, to think about how to remediate it. And I think the National Academies, having not been sideswiped by this conversation, have an important role in potentially helping with that. And there have been a lot of new faces through the media and elsewhere, new potentially trusted opinion leaders created as part of this pandemic. And the question of how to take advantage of that, the visibility of people who are not part of politics, but nevertheless are authoritative in the process of recruiting that trust is something else. But I do think we, as awful as it is, it was happening to Tony Fauci and others, it does suggest that we need to surround our scientific leaders with other fresher faces who can regenerate that level of trust.
David, this is Adam. I just want to associate myself with your comments because I've been thinking a lot about those comments and the issue of trust and the erosion of trust and how to rebuild it, and how to weave that theme into the report that ultimately comes out of these working groups. Because if we're not able to, many of these recommendations will never get anywhere other than the paper they're printed on. And whether they are government scientists at NIH or FDA or CDC, or scientists working on vaccines for COVID-19, or trying to figure out new ways to prevent chronic illness, without that foundation of trust that was the kind of the hallmark of these leaders for our country and the world, I worry that we are not going to make it very far.
Thank you. I really appreciate those comments, and I'm going to take those as, I think we're all going to take those as a challenge, both for the further work of the National Academy of Medicine collaboratives on addressing these issues in the pandemic, and in the work that we're doing beyond that to build trust and to hopefully make progress on the very challenging issues that you all have laid out. So, Joanne, I want to thank you for driving an excellent and sobering discussion, but I want to thank you and everyone else today for helping us to see a path forward. Among the key themes that I heard, trust is obviously one, how to build that to enable more progress, fragmentation in terms of many aspects of our response, and urgency, because all the issues that we're facing in the pandemic, they had those cracks were there, the problems were there beforehand. Mortality rates in the United States were rising before COVID became the #3 cause of death in the United States at a much higher rate of impact than anywhere else in the world. The disparities in race and ethnicity, the health inequities were there beforehand, before we saw these exacerbated differences. But I also am going to take, listening to Dr. Montgomery Rice about her comments on resilience. That was another term that I heard a lot today. And there are some bright spots, plenty of examples of grit that we can build on, that you all have talked about in the different reports that were reviewed today, that can be the basis for a more effective response. We have more to do to bring them together, to link them to tools and practical steps forward, and to make them part of an effective approach for connecting with the public and policymakers to get to trust, and through trusted communications and transparency and science-based approaches to get to impact. But the foundations are there. So very challenging time for the country. Thank you all for the leadership and the frank ideas and especially the proposed actions to help us move forward. Mike, to close this out, I'd like to turn back to you for any final comments.
Well, I'll be very brief and say that I echo everything that you indicated, Mark, and underscored. On behalf of the National Academy of Medicine, we're very pleased to have had such a rich discussion. We're going to continue that discussion in our closed session. But in the meantime, I want to thank all of our presenters and the public and our colleagues in the who are partners of ours as we move forward to trying to identify an action agenda that will make a difference and gain the trust of the American people. So thanks to each and all, and we'll look forward to hearing from you as we continue to polish and work on and complete and roll out the conclusions of the various sector assessments. So I think now, Mark, we're closing this out, and then the members of the consortium panelists will be re-upping, or do we stay on?
I think we re-up, but and hopefully all of our consortium members have the contact information, the logins to do that. But just let me close out too by thanking everyone who joined us today. Great comments from all of you, and it's going to take all of us working together to implement the kinds of ideas we've discussed today. Thank you all very much, and stay safe and stay well.
Thank you.